Good morning and welcome to the 21st meeting of the Health and Sport Committee in 2019. We have received apologies this morning from Alex Cole-Hamilton. I would ask everyone in the room please to ensure that mobile phones are off or on silent. While it is acceptable to use mobile devices for social media within the room, please do not take photographs or record proceedings, as we will do that for ourselves. The first item on the agenda is the first of our evidence sessions in the formal and second phase of our primary care inquiry, and so I'm delighted to welcome to the committee Kim Hartley-Dean, Head of the Royal College of Speech and Language Therapists Scotland Office and representing the Allied Health Professions Federation Scotland, Sarah Conroy, Professional Advisor at the Chartered Society of Physiotherapy, Alison Keir, Policy Officer Scotland, the Royal College of Occupational Therapists, and Joanna Inston, Head of External Affairs, the British Dietetic Association. Welcome to you all, and we have about an hour for this evidence session, and so we'll take questions over that time. Can I start perhaps by asking each of the panellists to say how you see, how you define, first of all, the multidisciplinary team and how you see the role of your profession and other allied health professions within that multidisciplinary team? Kim.
Thank you. How we define the multidisciplinary team, the Staffing Act, in fact, set out for the first time a statutory definition of the multidisciplinary team, and it's, if I remember correctly, it's the team of health professionals who are required to meet the needs of the individual. But the multidisciplinary team is also defined within the Primary Care Clinical Professions Group 21 principles. If a definition of a multidisciplinary team, though, extends far beyond, in the papers that we've got in relation to primary care, both the SPICE briefing and the GP contract, for example, and all those documents, it's the view of the Allied Health Professions Federation Scotland that the definition is too narrow. It needs to be much broader. The multidisciplinary team in primary care needs to not just be the GPs, the nurses, and the few AHPs that are mentioned within the GMS contract or the workforce plan, which is OTs and physios, but extends well beyond to speech and language therapists, to art therapists, to the dietitians, to the 14 HP professions which the allied health profession are composed.
Sarah Conroy.
Okay, so I suppose for me the multidisciplinary team has to include everybody that can make a difference to patients, and I think I completely echo what Kim says. It has to include all the professions, and I think sadly that's what we miss out a lot of the time. We talk about doctors, we talk about nurses, and we forget there's an awful lot of other professionals out there that are required if we are going to kind of change the health of communities. So it's all of those professions. Yes, it's GPs and there's nurses involved, there's the families, there's the carers, there's the HP professions, and stacks of others who all are there to make sure the patient has a good experience and their needs are met. To see our role within the MDT, I see our role is very much around about helping patients regain their function, regain their independence, and get back on their feet, and to make the most and contribute to their communities, not to come out of hospitals and close the door and never the fresh air will they see again. And I think that's where we're sadly lacking at the moment, in that once a patient leaves hospital, we think of the multidisciplinary team as doctors and nurses, and that's who's not going to get independence back for patients.
Thank you very much. Alison.
Thank you. I would echo also, but would go further and say we need to think about our social care colleagues. So we also need to think about social workers and our support staff as part of that multidisciplinary team. And also our third sector colleagues, I think, are increasingly absolutely part of that multidisciplinary team. And as occupational therapists, we have a model where we're a finite resource. We would view ourselves as experts, but happy to share our skills to upskill other people in that primary care team to give the best response at the best time for people. And also, I think we've missed the patient ultimately as part of that team? And do we need to move to a shift where actually we're dealing with the patient as the expert in their condition, a much more move away from a medical model of care to a more patient-focused social model of care? As occupational therapists, we work with all population groups, but we put our main offer for primary care around frailty and older people, around people who have problems either due to ill health being at work, so staying at work or getting back to work, people with mental health issues who are often not deemed unwell enough for mental health services, so mild to moderate problems can be supported quite differently if we help them sooner rather than when they get to crisis. And also we would like to support people with long-term conditions who are beginning to display functional decline earlier, because we know from the evidence that if we're involved earlier, people have better outcomes and it costs less money.
Thank you very much. Joanna Hines.
I must echo what my colleagues have actually said as well with regards to the definition of the multidisciplinary team. It's all the allied health professionals, and it's obviously centred around giving personalised care to the patient and achieving the outcomes that the patient is wanting and is relevant to the patient. In terms of what the dietitian has to play in that role, we very much, nutrition, as you can imagine, is integral to practically all disease states. So that would include cardiovascular disease, as well as mental health disease, as well as diabetes, obesity, renal disease, liver disease, and we're very often forgotten. We're a very small profession, and in Scotland there are 681 dietitians for a population of 5.4 million, so that's not very many of us. So we have an integral part to play, but there's not very many of us. So one of the things that I would be wanting to say is that we need more dietitians, specifically in the primary care role.
Thank you very much. I mean, it's quite interesting to consider the four answers. That the first answer from Kim Hartley-Keane said it's too narrow, and then every other witness extended it further and further. So clearly there's a sense on your side of the table, so to speak, that narrow definitions are a problem. What is your sense of the public perception of the multidisciplinary team and how primary care is delivered, given the centrality of it to future plans? Kim?
I'd say, actually, reading the Phase 1 report from the public, that the public seem to have a more HP perspective on how primary care should focus than, in fact, we see in the more official documents. And so that's incredibly heartening. We have the majority of both men and women who would be perfectly happy to, in fact, see other professionals, and by that I mean, your survey identified all the HPs that they would be keen to see as first point of contact professionals. So there's I feel the public are wanting to do things differently. I think, having said that, though, there does seem to be still we do need to shift, as Alison was saying, from this medical model treatment type approach to primary care to one that's much more person-centred. In essence, GPs and our colleagues within what we narrowly define as primary care at the moment need to start behaving a bit more like AHPs, and it seems that the public are asking for that as well. They want person-centred, they want patient-led, they want to be owners of their own records, they want to be owners of their own self-management. So we would say that the public are absolutely right in wanting services that are a bit more like the way that AHPs are already delivering services.
Very much. Anyone else want to add anything? Yes, Sarah. Sarah Conrad?
Okay, sorry. Yeah, I think the example of first contact practitioners in GP surgery seeing MSK patients, satisfaction has been really, really high, and that model is one that has been rolled out really quite quickly across Scotland at the moment in light of the GP contract. And I think we've shown that actually these roles we're not a substitute, we're actually the experts. And just as AHPs are experts in their own right, that we do have a difficult four-year honours degree course to get where we get. So we're not there as substitutes, we're there because we should have been there. And I think there's many other professions that can step up. You know, we've got community respiratory teams, we've got teams that can work with the frail and elderly. And I'm sorry, you know, if we look at the principles of realistic medicine, patients don't just want more drugs and more surgery. They actually want to get back on their feet. They want to be able to play with their grandchildren. They want to be able to get out. And that's what AHPs have to offer. So I think the public are certainly on side. I think there's also something though there about making sure the public know what they can expect. I think too often patients come out of hospital and feel really isolated and feel alone and don't know that these services exist. Not basically because they're so short on the ground. You know, if you're waiting for weeks and weeks to see a physiotherapist or an occupational therapist that would allow you to start getting back on your feet, to start thinking about getting out or getting back to work, we can't afford to ignore these services. It's A, what the patients want, and B, reduce social care costs, and C, you know, help people contribute to society. So I think the public are on side, but I do think that there's a bit of work to be done to remind them of what the potential is of all of our professions, because we're so thin on the ground, they don't get.
A brief supplementary from Brian Whittle.
I was really interested there. I couldn't agree with you more, Joanna, about the requirement for more dietitians. It could solve a lot of problems in our society. But I think when the convener asked a question around public perception of how they would like their treatment to be, we've heard quite a lot of evidence and quite a lot of anecdotal evidence around this perception that the public are coming to you to make them better. But part of dietitian, part of physiotherapy and occupational health is enabling the public to help themselves to get better. And our evidence suggests that there's still a bit of work to do in that. I wonder, is that something you would agree? They want you to give them a magic pill, basically.
Yeah, I would absolutely agree with that, and I think we need to have a cultural change that actually your GP might not necessarily make you better. So if you have a long-term condition, it's how you have strategies to help you manage that condition, and that's around a very different approach to pitching up to somebody who gives you a medicine that makes you feel better. It's around helping break down what the problem is, setting goals, reviewing the goals, and making that very person-centred around what matters to you in your everyday occupation. But that's not what people expect when they go to their GP at the moment, so we need to shift that perception.
Another perception that patients have is that they need to see somebody face to face, and what a lot of dietitians do is education on a group level, be that could be a face to face education session, but it might also be an online education session. So again, there's a perception there that we need to break down and change and shift.
Okay, thank you, convener. Good morning, everybody. I'm interested in what you were saying, Joanna, about primary care and having more dietetic advice in primary care. Last week, Brian Whittle and Dave Stewart and I were at the cross-party group for diabetes, and we heard some really interesting research about how some folks are now in remission for their type 2 and not taking any meds anymore, and that was partly due to good, sound dietetic advice for people to participate in some of these studies that are shown really well. So I'm interested in, when you're talking about primary care, what do you mean by primary care? What does primary care mean to you all?
Sarah Connor.
To me, primary care is all the services that are out there in the community that will allow the patient to live well in that homely environment that we aim for. So it's all of these services. It's not just GP-led services. So we've got community respiratory teams, we've got community rehabilitation teams, we've got teams that look after the frail and elderly, and they're all out there and they're not GP-led, but they fall into this no man's land. They're not funded through acute services and they're not funded through the GMS contract. So they're in this kind of no man's land in the middle. And that's where we need to concentrate if we are really going to change primary care and really are going to support patients to live well in their communities.
Yeah. Just to expand on that, I think in the evidence that was the SPICE briefing and the the paperwork around this inquiry. There's a big gap in the information on what's already out there in the community that our GP practices are not linking up with. The majority of, in fact, AHPs work in teams that don't directly, that the GPs are not an integral part of, that we aren't engaging with them, and it would be great to join those things up. And I'll give you a few examples. AHPs are core to community learning disabilities teams, community mental health teams, children and young people services, falls services, community rehab teams, dementia care, weight management, pain management, ACE related services. None of those services in which AHPs operate are mentioned anywhere in any of this paperwork. It's going on already, and what we've got is this enormous disconnect. And my colleagues in CSP and wholly support the view expressed there is that what we need is a whole systems approach. We have to start thinking of primary care as being both what happens in the GP surgery and them being connected up with all those other services that are going on that are actually preventing a lot of people ever going anywhere near their GP. There's a lot, most of the HPs are already first point contact practitioners. You can self-refer to most and almost all AHPs already, and people do, and they get therapy, or they get the provision that they need, the best practice, the best support they need, and then they carry on their lives, and the GP never sees them. Nobody in primary care ever sees them, and I think we've got to start taking cognizance of primary care and in the community is much broader than the narrow focus of what we've been looking at, and I think if we could get that joined up, we would get we're in a much better position.
Alison here.
Hi, and I think going on from that, there's also a need for earlier intervention. So primary care potentially needs to shift away from people first have that fall or that problem to actually when they're first unsteady. So if we intervene sooner than we have traditionally, we could have much better outcomes for people. We can keep people better for longer, and it costs less money. So we almost need to even shift primary care further upstream than we traditionally thought of it.
Joanna.
And I was going to echo that point in terms of primary care should really include prevention as well. And there are lots of schemes that are run by dietitians which help to prevent illness. And that might be in schools, it might be in communities. We also have in Scotland 2 dietitians who are consultant dietitians in public health. And they do schemes in the community. What we need to do is make sure we can supply a whole system approach which includes making affordable, healthy food available to people and preventing the impact of food that is less healthy, which is more abundant and more locally sourced for our populations.
So there's obviously like a bit of a disconnect in collaboration with GP practices or the way that services are provided, and it's obvious to me that allied health professionals are crucial to delivering many services across primary care and secondary care as well. So I'm interested to how would you see health and social care integration and primary care of the future to be delivered in conjunction with secondary care as well? I guess how would you see that? You know, we need AHPs in community, in secondary care, and primary care. Obviously, that's where we're looking at preventative aspects as well. So, what needs to change?
Kim Hartlekin.
Thank you. I think one of the fundamental things that need to change, and having read the submissions from all my colleagues and from the and obviously being fully signed up to the Primary Care Clinical Professions Group principles, I think what we need to do is change the beliefs and attitudes that are expressed about other services, that about specifically, and I'll talk specifically about AHPs, both up, down and across the health and social care agencies, and I would say in the Parliament, in the government, and in the mass media. We've got an attitude or a belief that's communicated in papers in the way that we talk about those other services, as though, for example, that AHPs are somehow periphery, that they're some sort of an optional extra. In the paperwork around the GP contract, and in fact in some of the reports that you've had before you, AHPs are described as kind of second-class clinicians. We have a view that AHPs and the services that we provide are somehow, we're doing tasks that GPs simply don't have time to do, but they could do if they had the time. That is not what's going on here. AHPs don't do jobs that GPs could do if they had the time. We do jobs that GPs don't in fact have the knowledge and skills to do, even if they had the time. And I think that we have to start challenging. We need an education programme on the key facts about AHPs across agencies from top to bottom. Perhaps a core common undergraduate module for everybody involved in health and social care, and that would enable some of those relationships to develop further down the line. We need to start changing the narrative and the language about AHPs, and we need to actively challenge some of those misinformed views of what AHPs do at every opportunity. And I would ask, it's that as long as we've got this idea that everything is about what happens in the GP surgery, and we're not recognising we're not enabling that conversation between all those other services because they're somehow not, they're kind of secondary, I suppose. As long as we've got that attitude and those misinformed beliefs, I think that that's creating cultural barriers within health and social care, which prevent us moving forward to a much more joined up, integrated approach.
I've got Alison and then Sarah.
We also have a new opportunity with health and social care integration with the locality plans. So we have locality plans for each IGB that tells us about population and the population challenges in that area. So, for example, we know as occupational therapists in Fife, particular GP practice has a challenge around people who are not at work. And the options a GP has to offer to these people are limited. Medicine will not necessarily get them back to work. But an occupational therapist is now going into the practice to look at helping people look at the skills they need to get back to work, working with employers and taking that particular need that was identified through the locality plan and linking that to the staff that sits in the practice. The other thing I think for older people is we need to have a greater acceptance of the evidence that's increasingly in front of us. So if we look at the life curve work from Newcastle and Strathclyde University, which follows the plot of functional decline as we age. So as we age, we will all lose function. But increasingly, we know that getting old doesn't necessarily mean that we need to be really disabled. Older people can be fit and independent, but what we do know is there's a pattern to loss of function. So we know that when people first can't cut their toenails, there's a significance in that, because that's then followed by they then can't walk a certain distance, they then can't do their shopping. And we know that through evidence. And we know that if, as therapists, we get involved at that time, an intervention will cost about £2,700, and that will add 5 good years back to life. So it lets you be more independent for 5 years for a relatively small cost, because at that point, people have the ability to regain their function. Traditionally, we get involved when people are really dependent. So when people have lost that function, need major house adaptations, need large care packages, an intervention at that time costs £40,000, and we can't change a person's function. We've missed that window to do that. So we really need to think about where we intervene, and that should be sooner.
Before I take Sarah and Joanna, I've got a brief supplementary from Sandra White and also a brief supplementary from David Stewart.
Thank you very much, Nina, and good morning. I just wondered what you think about the GP contract, because obviously in the GP contract, they're seen as local clinical leaders. Do you think that is detrimental to moving on than what you're actually saying here?
Well, I think it's a good example of the sort of language that is unhelpful in a multidisciplinary team, where You have, well, I have to be really careful here because, obviously, you know, clearly our colleagues who are GPs are doing an incredibly important job as members of that multidisciplinary team. And I suppose what I'm saying is that everybody in the team is doing incredibly valuable jobs in order to deliver the person-centred care that the public are asking for. And I think as long as we keep communicating the belief, or those perhaps, as long as we keep communicating a narrative that says other clinicians aren't able to make independent decisions and aren't autonomous clinicians helping patients decide what matters, or not helping patients decide what matters to them, but hearing what matters to them and enabling patients, or enabling the people to live the lives they want to do. That is a little bit of a, what we do is we continue the narrative within the public sphere as well, that, oh, if I've not seen my GP, then I've not really received primary care. And we've got to start changing the way we talk about this in this stage here in the Parliament, as well as in the media, as well as in boardrooms. We need to start breaking down some of those misbeliefs that go on. So, you know, for one of them, for example, we've got this idea that physios do an awful lot more than MSK, OTs do an awful lot more than mental health, speech and language therapists do an awful lot more than kids. But they're the kind of narratives that keep rolling on. And we've got to try and change the conversation. And until we change the conversation here and in the media and in the boardroom, you're not going to change those beliefs in the community. Although that's why I was so heartened to read what the public were saying, because they seem to have got, actually, you know, I want my health service to do what matters to me. I want to be able to do the things that, in fact, it's the HPs enable me to do.
Joanna Hines.
I very much like the primary care home model, which looks at the patient being able to go into GP practice and be directed through a triage system, an informed triage system, to whichever professional is the most appropriate for their particular symptoms and their particular story. And that doesn't necessarily mean going to see the GP first. It may be that, say, for instance, with a dietitian, that if they've got a gastroenterology type symptoms, they may actually be referred or directed via the triage system to the dietitian, who would then do the assessment, and if there are any red flags, they actually refer in to the GP. So the GP isn't necessarily the leader, they're part of the team, which I very much echo what Kim has said, but that's how I envisage primary care in the future, really.
Thank you very much. Alison, and then I'll take the...
To echo that, I think, you know, GPs may be the leaders, but they may not be the leaders. So in Grampian and stroke services, the community hospital was traditionally led by a GP. It's now led by an occupational therapist, and the length of stay has reduced by 2 weeks. And that's because the approach to care is different, because it's a goal-centred, what matters to you approach to care rather than a medical model. So sometimes different professions are better placed to be the leaders.
Thank you very much. David Stewart.
Thank you, Commissioner. Can I just go back to Alison's point, which I thought was very useful, about indicators and dependence, the inability to cut toenails, which then leads to problems with mobility. If I can just use another example from our diabetic group, of which there's 3 of us here. The other issue is the monitoring of foot pulses. In diabetes, as you know, it's one of the main reasons for amputation. And certainly in my past dealing with diabetic nurses, they'd be concerned that some care homes weren't monitoring pulses, with the obvious effect that they weren't aware that there was potential amputation. So these things are absolutely key, and I think Alison's example was extremely good on that front.
I think that's more a point than a question.
Yes.
Emma.
Just also to pick up, we've had feedback about welfare specialists being embedded into GP practice, so they're not necessarily allied health professionals, but they're professionals that have helped actually reduce. Recently I heard about somebody who was given antidepressants instead of debt consolidation advice support. So it's like we need to look at the whole, what is it that's going on with the patient. So if the GPs are the gatekeepers, so they're seen as the gatekeepers or the leaders. How that's the current perception, is if we build this whole care round the GP practice. So are you saying that we really need somebody to triage the person who then is a knowledgeable, the triager needs to be very knowledgeable about then how are we going to direct people to whichever specific allied health professional?
Joanna.
We have looked into this particular case in great depth in dietetics, because we have in, I can say in Somerset, so it's not in Scotland, a dietetic-led gastroenterology clinic in primary care. And what they have done is they've given an algorithm to the receptionist, who will ask a series of questions, and depending on the answers, move on to the next question, and then determine whether to refer that patient to the dietitian in that clinic without seeing the GP, or if they're already under the care of the GP for that particular condition, then they would go straight to the GP. So there is a way of actually doing that without putting too much onus on the receptionist, because of course they are not trained, medically trained, but they can follow a quite simple algorithm which will enable the direction of the patient to be determined without too much stress, really.
David Connor.
Where you started, Emma, with your question was around, how do we join this up and, look at the funding and, primary care. How do we look at it? And it's about looking at a patient pathway. And, I completely agree. Not every patient has to end up in their GP surgery. Not every patient that comes out of hospital, needs to be back in the GP surgery. But they do need help. They do need services. And it's about making sure that things aren't siloed, that we actually look at the entire pathway and the funding follows the patient, rather than having funding that sits here for acute, funding that sits here with the GP contract, and this kind of IJB for HPs probably at the moment, this kind of no man's land of who's funding that bit in the middle. So it's about joining it all up and making sure we don't have funding silos. And I think an example I would use, recently there was a meeting, Future AHPs in primary care, and we were talking about lots of examples, and we talked about the use of community respiratory teams, so using dietitians, OTs, physiotherapists, nursing colleagues to actually work with patients in the community to keep them with COPD, keeping them away from hospital, managing, keeping them able to self-manage. And we were talking about this as an example of where we can make a real added contribution. And it was suggested, well, that doesn't really come under the GP's budget. They don't, once that patient's in a blue light ambulance, they don't really mind. So it's about, whose budget does that come under? Because it's going to save money for the GP, it's going to save money for secondary care, it's going to it's going to improve that patient's life, and it's what that patient needs. But whose budget is it? So I think it's about joining it up and making sure that we look at pathways and the funding following the patient, rather than being in siloed.
Briefly, Kim Hartlicke.
Yeah, just to add to that, what you've described is a one-door policy, which makes a lot of sense. Sort of everybody knows where they've got to go, and they go into the building that is their GP surgery or the primary care hub, and somebody signposts them to, using perhaps an algorithm, signpost them to whoever would seem to be the best person for them to see initially, and that could be any first point contact AHP, which is basically all of us. The alternative, of course, would be to have many, many, many doors for people to be able to get into that, to be signposted to the right people. And why would we want to narrow it down to one door? What we've got is, we've got these community, as the teams I talked about before, we've got community mental health teams, we've got community learning disabilities teams, we've got loads and loads of AHPs out there in the community, perfectly capable of signposting people to the appropriate people, and in fact they already do that. We refer people on to our colleagues all the time. And if we were to start thinking about enabling people to access services in the ways that they find easiest, it's the person that they're bumping into already that would be the help. not needing to go to another place in order to access services, making it much more fluid. Although there obviously are, there's the benefit of clarity when it says this is your primary care hub. I think if the objective is for people to get as quickly as possible to the right person at the right time, we need to create multiple ways of people doing that. I think, though, that the only way that will work is in the context of a much bigger or of a much better public awareness, informed by a positive attitude to multiple doors, a much greater public awareness of who's available, what do they do, what can they do for you. And we need to invest in doing that seriously, because at the moment the way that we're promoted, the promotion of services like AHPs tends to be down to AHPs themselves, busy clinicians themselves, trying to, as much as possible, do tweets and raise awareness and do stands everywhere. That isn't going to cut the mustard in terms of
there is
changing
an argument that
attitudes.
says a single door is helpful for the patient, but Emma.
Yeah, we've heard some, there's a bit of ambiguity from the fact that, like, GP practices, they're independent practitioners and they employ their own staff as well. And so this might be, I guess it's a different subject, but the new vision appears to anticipate that this model would blend seamlessly with Health Board and then other local authority employed staff as well. So I'm wondering if you think that any current variation in employment in GP practices, so their own staff versus NHS staff, does that present any new challenges to realising, the vision for primary care in the future?
Sarah Connor.
I think certainly in England, where they've taken on this kind of first contact practitioner roles for physios, for MSK patients, some of the GP practices down there have employed their own physios directly. I think for us in Scotland, we've most of ours are employed directly by the Health Board, and I think that's important from a governance point of view, from a training point of view, for succession planning, to make sure that they're still linked with kind of more junior staff and coming through. So I think what you're asking is if these posts, if the GPs employed them directly, would it be challenging? And I think that it would. I think it certainly would be from the models that we working from a training and development point of view.
Joanna.
I wanted to just mention that I cover the whole of UK, and part of that obviously is Wales. And in Wales, they are doing some research looking at how different unique professionals work together in the MDT team, and I think that will help with making sure that the team itself works properly and they're supported no matter how, because what needs to be supported is CPD, it needs the continuing professional development, the pastoral type care, supervision, all of those aspects of looking after a member of staff, be they in community services or be they in GP practice as a lone individual, as it were, in a multidisciplinary team. That professional still needs that support, and it's where that comes from that's the question, really, that needs to be answered.
That's what I was trying to say. Oh, much better.
Thank you very much. Georgia.
Thank you, Convener. Good morning. I'm going to come at this question from a different angle with the way the discussion's gone, because I was going to ask about cultural change, but we've already kind of discussed that to a certain degree as well. But one of the interesting aspects, we did an away day during the summer where us and members of the public all got together and we had a design a primary care delivery service from scratch. And nearly every one of us in the West Coast one anyway came to the conclusion that GPs practices weren't the be-all and end-all. It was effectively everything you're talking about right here now. Now, I've been an elected member for years and years. My hair used to be brown. And when I was a councillor or an elected member here, we've had these conversations, we've discussed this over and over. I've read more reports than I care to kind of remember on the actual, probably don't remember half of them, on the actual subject. Now, one of the things I'd like to ask is, how do we stop talking about it and create that cultural shift? And what is your role in all of that?
That's a big question. Alison and then Kim.
So I think, in answer to that, we need to be bold. So I think we have spent a lot of time doing tests of change, we gather bits of evidence, but then what do we do with that? And that's what you're describing in your report. So I know for us as a profession, we have some evidence around our benefit in primary care, but we don't have evidence right across Scotland. But I would argue that the evidence we had is completely transferable. We know that we can reduce return visits to a GP by more than 50%. Now, surely evidence like that is strong enough to say we need to just make that change. We know also around the evidence I talked about around seeing people sooner gives better outcomes and saves money. So we need to just say, probably we've got enough evidence now that we know we need to change things. We also know we can't keep carrying on doing what we're doing. So I think there needs to be a real drive from government to say, actually, we're going to do things differently and to be bold and take that forwards.
Kim Hartley.
Thank you. Thank you, George, for the question. I think, echoing absolutely what Alison's saying, that we have all this evidence that comes forward, and then the narrative becomes a conversation about the crisis in one profession. There's actually a crisis across the multidisciplinary teams in terms of workforce, and therefore that informs the thinking. We need to act on the published policy. All the policies that we see about primary care are talking about AHPs and multidisciplinary teams. Let's actually do it. And we need to act on the evidence base, as Alison's just talked about. And in order to do that, we have to improve the AHP service capacity through funding, workforce planning and education and training. But in order to make the change in the decision making that happens both in government and at board level, whether that's an IJB or health board, we need that intelligence about AHPs to actually be at that table. And at the moment, it's not. So we need to establish an all AHP informed leadership on those boards. And once that's there, then all that evidence that Alison's talked about and we've all talked about will be repeatedly referred to when there's decision making going on. And it will be up to date, and it won't be overshadowed by the unfortunate wrong beliefs and attitudes about AHPs. It will actually be informed of, well, only an AHP leader will know that there's been a test of change somewhere in Scotland that's created a huge difference. And therefore you need that intelligence around the board table, and at the moment we don't have someone informing those decisions about what we invest, what workforce we invest in, what services we set up. So both we need to start reflecting the evidence in our decision making, and the only way that we can do that is by having someone that knows about all that intelligence at the table at the time the decision's made.
In answer to your question, I think there's a role that the associations for the professionals can take, but I think that needs to be supported by something through the NHS or through government to promote the role of the dietitian and all the AHPs in primary care for the public, but I think not just for the public, but also for GPs, because GPs aren't aware of how to use AHPs necessarily. So that's something definitely which I say with caution, because at the same time you don't want to raise expectations and not be able to meet those expectations by having enough of the AHPs that people are crying out for once they've seen this awareness campaign. So there's that as well.
Sarah Conroy.
That with the MSK FCP roles, MSK roles that we're seeing in GP practices, GPs through the contract asked for 280 additional physios to work in these roles, and we've got recruitment and retention issues as well. So we've maybe 70 or so in post. I think we've had a commitment that we can increase the workforce over the next 3 years, but that decision seems to be stuck. We've been promising this for last January's intake. We look like we're going to miss it for this January's intake as well, and so it has to be a vision of the future. We have to plan this, and we don't have proper workforce planning for the HP profession. So if you look at the SPICE guidance, we don't even get a mention. We can't even tell you how many HPs there are out there. So we don't know how many there are. How can we plan for the future and plan for new models? And yes, we can make huge differences. We all know we can make huge differences, but we need to fund that and think about the future and make sure we've got a supply coming through.
Stuart.
Ask part of the ongoing debate as well, and cultural change that we talk of is in long-term conditions and self-management of that. Now, in my opinion, you guys are an important part of that. You know, I always use the example of my wife Stacey with multiple sclerosis. It was a physiotherapist that taught her how to walk properly with crutches, and she'd had them for about 10 years at that point. You know, so a doctor wouldn't have made any difference on that scenario. So my question would be, you know, how do you get yourselves into that position so that you can be there for that individual when they're looking for that? You know, because how do we join that? How do we get that to that position? Because that's a difficulty.
Say that and then Kim.
I think we're continually shouting. We've got lots of research, for example, pulmonary rehab. You know, the Cochrane reviews have said, like, no more evidence. We know it works. We know that you teach patients with COPD to self-manage. We know that you give them the skills, and we know that it reduces hospital admissions. We know that it reduces prescription costs, but we still don't have it universally for everybody across Scotland. So, you know, so what can we do? We can continue to put the evidence out there, but as Kim says, we need seats on board tables. We need when policy is made that it doesn't get lost in the civil service bit in the middle, and so when it comes to the board, once again we get more doctors or more nurses and AHPs aren't even on the agenda. We know that what we do can make a big difference. You know, long-term conditions, frailty, you know, MS, strokes, cardiac conditions, COPD. You know, you can't help patients live with these conditions without AHPs, and, you know, I would obviously say physiotherapists being involved. We know we've got the evidence, but we need investment, and we need to.
Kim Hartley-Keane, followed by Alison.
Thank you. I suppose I would just wonder how long people would wait to see an AHP if they knew that right now they can phone up their local AHP services, for example, their speech and language therapy services, and say, I think I might need some help with speech and language therapy. And that's it. That's what they have to do. It's a self-referral system. People don't know that, and so they don't do it. And so they have to wait to go through a pathway, hoping that the GP or whoever it is they fall upon knows what it is speech and language therapists do or other AHPs do, and then they might get a referral, or they might be signposted to an online resource. We don't need to do that bit. We could just go, if people knew, oh, hang on, I'm having problems with my swallowing seems a bit funny. Oh, I know, speech therapists deal with that. I think I'll give them a wee phone and see if they can help me. There you are.
I'm pleased to tell witnesses that this is the BBC's online coverage of Parliament this morning, so all these good awareness points that are being made are reaching a wide audience. Alison Keogh.
George, I think to go back to your point around cultural change, that is the thing we need to really focus on. So if I give you an example from Wales of a young lady with disability whose care was managed in a traditional medical way. So the lady, her own goals when she was asked what she wanted was to put her child to bed and to go shopping. But around a medical model, her incontinence was managed, her fatigue management was managed, her medication was managed, and over a 2-year period, she had more than 200 interventions from therapists, nurses, doctors, and in that 2-year period, she wasn't putting her child to bed and she hadn't gone shopping. So actually, that thing around what is important to you is where we should start, and where AHPs are ideally placed to help people, rather than looking at the problem. What is it you want to do? What's our solution is where we should start from.
No question, convener, which is effectively, you know, it's the main question is, you know, can you give me specific examples of your individual professions where innovation and you working within the current system has made a difference in people's lives? You know, give me actual examples. You've kind of done that already, Alison, but it kind of leads on to it.
So just to reiterate that we would really push for care that starts with what matters to you is actually not a more expensive option. It's an option that lets us tailor what we need rather than work around what we think we need. And that's two different things.
Supplementaries from Emma Harper and from Brian Whittle.
It's just a quick question, actually, for Sarah. The government are due to publish a respiratory care action plan before the end of the year, and I'm assuming you would think it should contain pulmonary rehab, because we do know that the evidence is that PR keeps folk out of hospital. And I'm saying this as the Lung Health Cross-Party Group convener, because I know about the respiratory action plan that's due to be published. So I'm assuming you would support PR being contained in that national action plan.
It has to be.
Yeah.
Thank you very much. Brian Whittle.
Okay, Kavina, just to follow on from George, I was going to bring this up later on in my own questioning stuff, but in terms of culture, I wonder where we're hearing a lot around the government putting a lot of emphasis on training of 800 new GPs, and I'm wondering within I've always questioned whether or not that's actually what we need. You know where I'm going with this. How much input had AHPs into the definition or defining of a new GP contract, and how much influence should you have in terms of delivery? It should be around delivery of service. It shouldn't be around numbers of GPs. That's kind of where I'm getting to, and I'm not convinced that the number of GPs we are short just now is actually going to deliver the service we need going forward, and how much input had AHPs into that sort of, because the culture has to change from the top, from here, from this place down. So that's my question.
Sarah Connor.
The change has to happen from the top, and no, we probably weren't very much involved in the GMS contract. And I suppose for my profession as physiotherapy, we were lucky that we had a snippet in there that highlighted the difference that physiotherapists and MSK physiotherapists can have in GP practices. And we've demonstrated that time and time again. You know, increasing the freeing up GP time, reducing secondary care referrals, reducing prescription costs. But that's one example. There's lots and lots of examples. You know, the frail elderly populations can, you know, we can't manage these conditions without occupational therapists and physiotherapists. Respiratory conditions that, you know, I've already touched on. You know, all of these we have to be involved in. And I think it's disappointing, perhaps. You know, we had the National Clinical Strategy, you know, a couple of years ago, and we talked about healthcare and social care. What about that big bit in the middle that is rehabilitation, that is enabling patients and really giving them a quality of life? And if we continue to have papers like that coming out that ignore the huge contribution that AHPs can make in the community, then we're just going to keep getting more of the same. GPs can't continue to give tablets to manage frailty or, you know, or multiple long-term conditions, and we can't keep having people in hospital. We have to look at this big bit in the middle and actually fund it properly and embrace what we want to deliver for the population.
Thank you very much. I know there are witnesses who'd like to add to that, and I'm sure the opportunity will come in the next area of questioning, which relates to Brian's supplementary. David Stewart.
Thank you. Yeah, can I move on to workforce planning? Could you describe your own workforce planning for your own individual occupation, and will that meet the new demands of the new plans we have in the future for delivering primary care?
I think if I can start with Kim, I know Sarah's already said a little bit about the workforce side, but I'll come back to you certainly, Kim.
What's the HP's workforce plan? As Sarah's already said, there isn't one. So we're waiting, like everybody else, for the integrated workforce plan. But what we want it to do is to invest and to deliver on the actions to address both the common and the specific allied health professions workforce issues. So we can describe what the issues are and what, therefore, what the solutions would be. The common workforce issues for AHPs is that there's too few funded posts to meet demand and provide the transformative health and social care that we want. It's not necessarily that we've got too few AHPs out there or people trained to do AHP jobs. There just aren't the jobs to go to. And I can give you many examples. That's the common issue. but there's also different AHPs also have very specific workforce issues. So for some, there's a huge demand to join the professions, to join a profession, but there are too few training places available to allow access to HP degree or other courses. So that's an issue that Sarah, I'm sure, will touch on. For some, there are issues attracting people to join the particular allied health profession. And for some, there are not enough AHPs being educated or willing to work to fill available posts. So each of those different issues have different solutions. There's one which is the common one, which we need more AHPs, but how we create and fulfill that more AHPs is going to be different for the different professions, because, for example, in my own profession, we don't have any problem getting speech and language therapists to apply to become speech and language therapists. In fact, we don't have enough places to train them. But having done that, when we come out, although there's an enormous need, there simply aren't the jobs for them to go to. So that's kind of demotivating for people. So I think in how do we, what would we want to see in the integrated workforce plan? Well, as I've said before, we need to stop focusing on a crisis in one profession. This is a multidisciplinary team issue. We need to act on the evidence base of clinical need and the impact that each profession has on that need, as several of my colleagues have said today. And we have to improve the capacity of the HP workforce by addressing both that general problem of there being jobs to go to and the supply to that workforce and all the nuances around that.
Okay, I think you've covered just about covered most in there. It was the primary care transformation plan in the back of the GMS contract that has, for the first time, has given us any sort of workforce planning and physiotherapy, and that's for one small part of our profession for MSK, when it was actually recognised that the difference that we could make, all of a sudden we've got this big ask for all of these new physiotherapists working at quite an advanced level within the next 3 years. And so for the first time, we believe they were going to be in this workforce plan and we're going to see some funded places. But it's quite little and it's quite late, and it's about one small part of our profession. So it is about really looking at our contribution across the piece within hospitals, within mental health services, within communities, and really looking to see what the future looks like. There's no problem recruiting to physiotherapy undergraduate places. There's 3 times the amount of people that apply for the number of places that are there. We have got recruitment issues across Scotland now at the moment. There just aren't enough physiotherapists to fill the posts that are available. Yet we've still funding-wise, we're still way behind the nurses and how these places are funded and how they're planned for. We've not seen an increase in the number of physiotherapists being trained in Scotland for about the last 10 years, and that's due to funding issues. So there's lots that needs to be looked at for all the professions there.
Alison Keir.
I think it's also about are the jobs in the right places. So historically the jobs might have been in secondary care, but now we know the evidence suggests we're better placed in primary care, but I don't quite know that the jobs have caught up with that yet. So for occupational therapy, we roughly have the number of occupational therapists equal to the number of jobs in Scotland at the moment. But actually, if that changes, so we're doing things differently, our workforce will look different in the future.
Could I ask you, convener, just a question on, probably poaching is not the correct technical term, but moving from one setting to another. Let me give you an example. I was speaking to a GP in Elgin who recruited a community pharmacist, which was great, but then there was problems in the high street with some of the firms being able to then recruit the replacement for that. Is that an issue that you're familiar with in your various occupations?
I think it is, but I also think there's an opportunity to do things differently. So it may be that we keep that very specialist area of expertise, but work with different colleagues. So in our housing services, we've trained up housing officers to do basic grab rails. Previously, you were on a waiting list for an occupational therapist to do that. So we've had to look at how we use our workforce so we're best used to best effect, because we can't be everywhere. Yeah.
And then Sarah.
I echo in a lot of what my colleagues have said. In particular, there aren't the jobs coming up in primary care, but also to train a dietitian to be able to work in primary care. Certainly as first contact practitioner, they need different skills which aren't taught at the moment in university when they do their degrees or their masters, etc. So there is that element as well, which we need to address, and that's done via the association that I work for, because we determine the curriculum. So there is a bit of joined up thinking which we need to do internally, but that needs to go hand in hand with having the jobs available in primary care.
I would just pick up on your pharmacy example. I was in Highland last week, and in Highland they've wanted to roll out the MSK FCPs right across Highland relatively quickly. And in doing so, they have taken 12 posts from the core service to prop up these FCP posts in GP practices. So that's another example of not looking at the pathway. So you might be able to see a physiotherapist relatively quickly as that first point of contact in a GP practice, but you've got no core service if you need ongoing therapy. So it's huge issues. We're paying Peter to, or robbing from Peter to pay Paul, and it's about moving these posts. It's about having representation on IJBs, because as Alison says, that's where we'll make the difference. But if we're not round the table, how are we going to
so you
have a post
can I just ask, perhaps particularly to Sarah, about tools that are used in workforce management? One of them is the ISD dashboard, which looks at vacancies and turnover. Is that something that is a useful tool for you?
No, it's not useful. For example, because the data is really well, I go to the boards, or I go to Leeds across Scotland and ask what their vacancy rate is. And for example, in Grampian just now, they'll tell me it's up to 40%. In Ayrshire and Arran, in their MSK service, it's sitting about 30%. But if I look at the ISD data, if I look at the dashboard, that's the word I was looking for. If I look at that dashboard, it's telling me that actually vacancy rates across Scotland for physiotherapy sitting between about 2 and 4%. So there's a huge discrepancy.
So why is that?
I don't know. It's something that we're discussing within our profession at the minute, to actually ask these questions: that why is this data so skewed? Why is what everybody's reporting on the ground so different than what's shown on the dashboard?
So you've contacted ISD to say there's a mismatch between...
We have a meeting on Friday to discuss our next steps around that, and we've asked each board to go away and come back with what their figures are looking like, and that's where we're getting figures like 40% and the like. So there is certainly a big mismatch there. I don't know if other professions are finding the same on that.
Anna?
The other limiting factor is that in the sort of training of dietitians in particular, obviously I can only speak for them, is that there are only 2 places in Scotland that can actually train dietitians. So that's 2 universities, and they will only take on a 30 cohort of 30 each year. So there's the limitation from that perspective. So if we need to grow the workforce that go into primary care, we need to think about having more university places in order to train the ones coming from from students.
And that boils down to the funded numbers that's allocated to each university. So it's obviously a Scottish Government issue that needs to be looked at on that front. Okay.
Briefly, Kim Hartwick.
Yeah, sorry, I will make it really brief. I was just picking up on your question about has there been, in shifting therapists to do one task, do you lose in another area? Yes, that's certainly what's happening in children and young people, or there's evidence to suggest that that's what's happening in children and young people's services, where, for example, speech and language therapists are working a lot more at universal and targeted level, creating communities, rightly, around children that help their outcomes. But what's happened is that more traditional, that one-to-one direct specialist level provision, the therapist can't do that too. So that's an issue. And my colleagues from podiatry have made a submission to the committee, and I'd just particularly like to highlight that they're experiencing high vacancy rates in Scotland as well, particularly in NHS Grampian. There are big gaps there, and I think that experience, as Sarah has described, of us hearing from our members about the vacancy rates that they've got and the issues that they've got, and then looking at ISD figures, and it doesn't always look the same.
Okay, that's very useful.
It's very helpful for the committee when we come to take evidence from the government. Miles Briggs.
Thank you, Convener, and good morning to the panel. I wanted to follow on that question because we've heard from David Stewart in terms of where we are with workforce, but how currently is that then being determined in your view for future workforce planning? Is ISD figure where you think the Scottish Government is basing its predictions, and what feed-in do you have as organisations to that workforce plan?
Sarah Conroy.
I would just like to say that I don't think there really is a workforce plan. So I don't think there's a lot of thought given to AHPs. Like I say, the only reason that the physiotherapy has had any kind of workforce planning in the last goodness knows how many years is because of the GMS contract and because of the first contact practitioner MSK posts that have been asked for. But for actual other services, community rehabilitation services, COPD services, acute hospital services, there's no workforce planning really going on at a high enough level to predict what might be needed. So we know we've got an ageing population, we know we've got patients living longer with comorbidities, and I think it was Alison that said, you know, you can grow old and not be disabled, you can grow old and still be able to function and to go out and to have a good quality of life. And that's our services that you need to do that. But nobody's looking at the changing demographic and thinking how many more AHPs do we need. So I don't think it's really happening, full stop.
Can I just ask as a supplementary to that, who should be doing that?
Well, I think there's workforce planning goes on for the medics and for the nurses, and I would like to think that the Scottish Government should be workforce planning for the entire multidisciplinary team. I think we can all show our worth and we all show what we can do and how, you know, the public need us. So yeah, I think it should be Scottish Government.
Just to illustrate that point and totally back up, of course, what Sarah's saying. We've had a GP contract which has communicated messages that aren't right about what AHPs do. We've had a national clinical strategy which failed to mention AHPs altogether, practically. We've had a leadership gap in Scottish Government for some time. We've not had a Chief Health Professions Officer in post for a number of years. That post is now being recruited to. So the capacity and the, let's just say, the sort of way that we're planning at that national level hasn't unfortunately engaged AHP intelligence and information as it needs to do if it's going to deliver the service that people describe they need and want.
Thank you very much.
And to pick up on George Adams' question, I was quite interested in, this is something which we can maybe write to others who won't be giving evidence to the committee, but when we did the public sessions, one of the interesting things was where people tried to put services if they designed them themselves. And most people said actually that around a right to referral. So instead of the GP being the gatekeeper to every service, how would they access in their world? And actually it was technology they jumped to. Now, we know how bad technology is throughout the health service, so that solution isn't there now. So I was interested in terms of what you said, Kim, if you could recommend, or as a panel recommend to the committee, how we actually create that for the work we're about to do. What would that look like today for you to try to break that barrier so that patients can access the services your members provide?
I think there's something about access, isn't there? But there's also something there about availability once you can access. So I think most, certainly for my own profession, we've had self-referral for a long time for community services. But you have to know, you know, there has to be a knowledge there about what we have to offer, about how you go around that. And once you do self-refer, if you've got to wait 12 weeks or 15 weeks or 16 weeks, is that really a service? And if you come out of hospital and you need that service to, you know, you come out, you're weaker, you're frailer, and you need to get back on your feet, is waiting 16 weeks really a service? So how it would look, it would be a well-resourced service that you could self-refer and somebody would turn up at your door. How we achieve that, we've got in some areas NHS 24 or the MAT service. But again, you can have advice, you can be signposted to a website, and I think there's a huge place for that. But there is also sometimes a need for services and signposting, sometimes not always to health professionals, but perhaps to the third sector or to voluntary organisations where you can perhaps get some of that help and advice and support to get yourself back on your feet. But we have to get better at signposting to that.
Anston.
I'm going to give you an example, Miles. For dietetics, if you've got irritable bowel syndrome, for instance, and you are looking at, certainly in England, it would be NHS Choices, which is the online health information site, you can access, if you look up IBS, you can access a webinar which gives you information about how to self-manage your IBS condition. But at the end of it, it will tell you how to self-refer to a dietitian. So that is one way in which it's being used, certainly in England, and I would love to see that spread across, perhaps with NHS Inform, I think you have in Scotland, don't you? That could also be used here. And that's one way of providing education, but also if you then, having done that education, think you need to see a dietitian, you can refer in yourself to a local service.
Okay, thank you very much.
And finally, in terms of making that happen, do you feel, given the waiting times we currently see across AHPs, that that's been discouraged because you have to sort of control supply in some way? And is that something your members are reporting, and how can that change? Because I think often, I did a visit yesterday to a community pharmacy here in Edinburgh, and we were talking about the work going on there, and almost this discussion about, oh, well, I'll go and check the doctor's happy with this first, and how that can often mean that people end up wanting to see their GP even though they've accessed allied health professionals as well, and it doesn't then become, you know, for multidisciplinary teams, who's in charge of that team often becomes the GP. So how do you collectively try to look towards that being different? I think that's something which is still a barrier when we're in GP surgeries, because often that's where, until you have that flat model, it's difficult to see how we can change that.
Thanks.
It's a few questions.
Briefly, please, Kim and Joanna, please.
Thank you. Certainly, allied health professions are actively encouraging people to self-refer. As Sarah says, all HPs, or most HPs, are self-referral. The issue is people, both our colleagues within the health and social care family and the general public, don't necessarily have the awareness and knowledge of that one, they can do that, and two, that they don't need to go, that actually all those clinicians don't get directed by their GP. They have the skills to assess, to take on referrals, assess, treat and discharge people as independent clinicians. I think one of the things, and that message isn't being clearly communicated to enough people, as I've said earlier. I think what we know, so the links between socioeconomic disadvantage and poor health and well-being outcomes is irrefutable. What we also know about socioeconomically disadvantaged communities and people is that there's high levels of people, there's a lot of people living within those communities or within those communities I should say, who live at a communication disadvantage. So that means they may have difficulties for whatever reason accessing things online, or from reading letters, or from doing all those things. And so the Scottish Health Council last year published quite a detailed report on what should we be doing in order to make that information, to make that door, if you like, communication inclusive to many, many more people, and the public informed what that would look like. And as Sarah says, the well-resourced services behind that door are absolutely essential. But I think there's, we're absolutely would encourage people to self-refer to allied health professions in the full knowledge that they know what each therapist does.
Thank you. Joanna.
I think the answer to your question is confidence. So it's patients' confidence, and that comes with raising awareness, and that comes, I would hope, would come through the associations for the professions, but also through government and through NHS, because people value what they hear from the NHS, perhaps more so than they value coming from the professions. That needs a cultural shift, and that might take time. I'm going to give you an example of what dietitians face. It's not confidence that the doctor would know better, but it's more that we're battling against nutrition experts online. So we're a lot of charlatans out there who do a 4-hour course, call themselves nutritionists, put out that you need to drink celery juice and that will cure your cancer. And so quite often, if a patient comes to a dietitian, we have to unpick and undo a lot of misinformation. So that's something that we have to battle with. But I think in answer to your question, it's to do with the awareness raising.
The key sort of point to my question was around information for the public, really. So, you know, when you look at maybe 2 winters ago when we had the winter crisis, Annie Wells and I visited a GP practice in Glasgow, and the first thing up on the board as you walked in was, "Why are you here?" Now, not the most welcoming message, but at the same time, it was trying to get people to the right healthcare professional, trying to send people to an optician or across the road to the pharmacy. So what would you like that to look like is really the question, because a public information campaign can often just get lost, and we've heard the communication issues, which Kim has also highlighted.
Alison Keir.
So in our children's services, we've moved to a model of request for assistance rather than referral. And what happens with that is people are contacted very soon after they've contacted the service, and that may well be that they're then signposted elsewhere, because what happened previously was everybody was put on a waiting list. So actually that earlier contact gets the right people on the waiting list, so your waiting list is less, so you get seen more quickly, but it also means people have had a conversation. It stops that anxiety, it answers questions quickly, so we've actively encouraged people to come to us quickly rather than go onto a waiting list and be faceless. Yeah.
Thank you very much. My apologies to both witnesses and members. We are rapidly running out of time. I have closing brief questions from Sandra White and from David Torrance. Sandra White.
Thank you very much, Convener. Lots of my questions have been answered, so I just want to be very sharp and to the point. Obviously, awareness is something that we need to put forward, not just the public, but the GPs as well, and the culture change and the public understanding. But for me, as you said yourself, there's this gap. Anyone can go to the GP, and that's the first point of call. So how do we get over that part of the GP being the first point of call? And as has been said before, people are not aware of the services that you have, that they're able to get. But they go to the GP or they're in the hospital, what happens then? It disappears. So I think possibly you've given me the answer, but what can we as a committee do to ensure that the public are aware of the services of the allied health services?
Kim Hartley-Keane.
Really key, the committee and what you say as MSPs, and how it goes back to that is to communicate your understanding and knowledge and beliefs about AHPs, and for that.
Sorry for interrupting, Kim, but what I'm trying to say is people are directed to the GP. They're the gatekeeper.
Mm-hmm.
And somewhere along that line, it's lost. Nobody knows where to go after that. So why can't we just go straight to the allied health professionals? What's stopping us from doing that? Or what, the public?
Yeah, I think my first reaction would be people not knowing they can just come direct to people.
Thank you very much. David Torrance.
Thank you, Convener. What are your frustrations and the barriers around information sharing and governance?
Joanna Enston.
It's a lot to do with the computerised technology that we have, which can sometimes be a barrier to sharing the information. And it depends how well set up in your locality you are with your information sharing with your colleagues, with the doctor. Sorry, what's the other part of your question?
What was your frustrations and the barriers around information sharing and governance?
Well, definitely the governance part, I would I think is more to do with making sure that you're collecting the right information. So, in other words, you're collecting information and you're keeping it confidential. And I think with sharing with colleagues, that's one of my frustrations, is when this is the last time I practiced, which was about 4 years ago as a dietitian. It was a case of sometimes it was on paper, sometimes it was on technology, and there's a lot of effort that goes into keeping both those systems going at the same time, which detracts from actually seeing the patients. I think that's my frustration.
Thank you very much. If any of the witnesses wish to answer either of Sandra's questions or David's question, then please do now. Sarah, followed by Kim.
As IT systems that speak to each other. I think even within primary care, you know, there's three different systems, and even if you've got the same system, it might not speak. I think I hear frustrations from physios working in primary care that although they're independent prescribers, they're unable to prescribe because whatever the system is, it needs an NMC number or a GMC number in which to prescribe. So they've done all that additional training, but they still have to have somebody else write the prescription. And I think in remote and rural areas, there's even more issues, again, just because I suppose, I was going to say, you know, getting access to IT systems when they're out on the road. So I think there's IT.
Just really briefly, there are many frustrations. If I can give you an example from podiatry, in some NHS boards, the podiatry service is well connected within their health board portal, and there are lots of benefits to that. So the ability to receive direct referrals from GPs, and to access patients' medication records and access patients' emergency care summaries, but that is not widespread. So what we've got is an inconsistent approach to bringing HPs into being able to be part of that multidisciplinary team information sharing. And I draw attention to the Primary Care Clinical Professions Group paper on information sharing, and it being very much, and picking up again on being patient-centred. It should be the patient that owns those records and decides who it can and can't be shared with.
Okay.
So.
Thank you very much. Alison.
Yep, so we've talked about the problems within health, that we can't share information within health, but we started today talking about what is primary care, and that's not just health, it's social care in the third sector. So actually the problem is much bigger. If we can't do it within health agencies and we want our team to extend, our IT systems don't talk to each other beyond that at the moment.
And a one-line supplementary from Brian Whittle. I think we've already had one answer.
Is this around this? Well, if that's going to be successful, should the patient own their own data?
I think if we're moving to a model of care that is patient-centred, then we have to view a patient as an expert in their care. So yes, I think there's definitely an argument for that.
Okay. Thank you very much on that very important point. Can I thank the witnesses for their attendance. Emma Harper has reminded me that she is hosting an event for AHPs in the Garden Lobby in February. I know the engagement of all the witnesses today with the committee will continue throughout our inquiry, and that we may wish also to follow up with witnesses on one or two points that we didn't reach today, and so if you're happy to respond to written inquiries, you will receive those from us. Thank you very much. We'll now briefly suspend to allow a change of witnesses. Apologies to our witnesses who have been very patient in awaiting this panel. But this is the second panel in our primary care inquiry, and I'm delighted to welcome to the committee once again Teresa Fife, Director of the Royal College of Nursing Scotland, Dr David Chung, Vice President of the Royal College of Emergency Medicine Scotland, and Claire Cable, Chief Executive and Nurse Director of the Queen's Nursing Institute Scotland. We also had expected to have a witness from Unison, but we have received apologies as unfortunately that witness withdrew yesterday. Can we perhaps start with the witnesses who are here by asking the same question I asked at the outset of the last panel, which is simply how each of you sees the multidisciplinary team and how you define that and see it going forward. Teresa Fife.
Thank you. The RCN is a member of the Primary Care Clinical Professionals Group, so our commitment to multidisciplinary planning is evident from that approach. 60,000 professionals we actually represent within that group. We work together. For us, multidisciplinary team working, when done well, is about actually getting the right resources, planning and care for people, utilising the best of individual professions. And that unique contribution of professionals is critical to MDT. So one of our frustrations sometimes is when people talk about multidisciplinary team working, it's like that everything everyone does, they do as one whole team. It's the planning of care, the decisions of care, the assessment and evaluation of that care, and then actually focusing on outcomes for people, but thereby each of the professions then make their own unique contribution to that care.
David Chung.
So I think emergency departments sit at the sort of interface between lots of things, and a lot of people who come to emergency departments do so not necessarily because they have, in old parlance, an accident or emergency, but they are in crisis of some kind or something's not happening elsewhere. So multidisciplinary working, I think, is fundamental to how we approach any of the difficulties we face, and increasingly we're seeing examples of good practice within that. So people come to an emergency department because they, let's say, are labelled as having a mental health issue, but as we know, it could be in fact due to acute distress or there's forensic issues. People come because of issues with, can be dealt with much better. When we say multidisciplinary, we're talking here within medicine, nursing, allied health professionals, but increasingly social work. You've got innovations such as the Navigator scheme, which kind of signpost people who come to emergency departments to other agencies within the community. And I think something which we need to see, perhaps, there are good examples, but making it perhaps uniform throughout emergency medicine in Scotland is this ability for us to signpost and access all these other resources which exist out with the emergency departments to, first of all, ensure that the people who are attending actually get the help they need, which very often isn't really from a doctor or nurse, even a physio or somebody else, but it's something else within their lives, and we're uniquely placed to do that. So we're happy to totally engage with this new way of multidisciplinary working, which 20 years ago probably wasn't thought about as being a core accident or emergency business. But we are where we are. People come to us because the lights are on, and it would be much better for us to enable these people to get the help they need, which will stop them having to access lots of other kind of cares elsewhere. So we very much feel that multidisciplinary care, from our point of view, reflects helping people sort out many different things within their lives, not just even in a medical way.
Claire Cable.
Thank you. Building on the other two responses, I think the importance is the fact that we are all supporting individuals, families and communities. And just as Teresa says, that may not be one coherent team working with an individual, but it's complex. In the vision for primary care in Scotland, the 21 principles that the Primary Care Clinical Professions Group put together, we talked about a network of primary care professionals across the public, third and independent sectors. And I think that's quite a helpful way of looking at the multidisciplinary team. It's not just multidisciplinary, but also interagency, a network of professionals working across those sectors.
I think it would be fair to say that the witnesses in the first panel all felt that the definitions used particularly by government or within the NHS, were too narrow and didn't specifically acknowledge all the different members of the multidisciplinary team. Is that something that you would share?
I think nurses tends to be used as a term to group a huge number of specialist professionals together. So within the primary care team, you will have general practice nurses working within general practice, clearly, and district nurses. But equally, you've got primary care nurses working across the age span. So you'll have health visitors, school nurses, and you've got people providing primary care in less obvious settings. So occupational health nurses will be working with people in workplaces, school nurses with those in a school setting, prison nurses who are working with those who are incarcerated or wider across the criminal justice system. So I think it's important to be thoughtful about that broad definition of where primary care is delivered, because it's delivered across settings, and sometimes we focus on the general practice or the community clinic hub, forgetting that primary care is delivered where people are.
Teresa Fife?
I think I heard from the previous session a lot about how we message that to people in the community. The language we use doesn't make it easy for them to know that there is a team there in different places. The other thing I think we sometimes get very caught with, we get very focused on buildings. So we keep referring to the practice, and it's a building. There's a range of disciplines, agencies, volunteers, voluntary services that work outside of that building. So if we think of, I heard the comment earlier about a door, that's access to services. And I actually think that's what we should be talking about. And then we're clearer about what that team is and how that team looks. For us, for nursing is a huge component of that multidisciplinary team. They are the only component that provide 24-hour services alongside with out-of-hours from other cover like GPs. So it's important to understand the different elements of the team, but I do believe there's a public messaging. We as the professionals group called for that. Get the public messaging right, get them to understand, but your own work at this committee showed the public understand that far better than perhaps we realise, and they want to understand how to access those team members in the right way.
Very much.
Just second what's been said, I think it's important to stress, as we say, it's interagency. So if you say multidisciplinary team to myself now or any other emergency medicine doctor, we are all thinking this, we're experiencing things like child protection, adult support protection, all the rest of it. It's as much, as I've already said, other agencies, local authority, as much as all the other various healthcare professionals as well. So certainly in my head, if you say that, I don't think it excludes anybody. I think that's the main point. But the trouble is you might not know who's there if you don't know about them. That's what I found as we've improved things. I've then become aware of different services available which I had no idea about, and I think that's perhaps a challenge for people working within healthcare as much as for the public.
Emma Harper.
Thank you, Convener. I guess I'll go with the question I asked the previous panel about defining what primary care is, so just so that we can hear from you what your response would be regarding that definition.
Core members of the Primary Care Clinical Professionals Group, we worked so hard as a group of primary care professionals to be thoughtful together about what is it that we're talking about. And I think the definition that we came up with feels good. It feels as if it captures all those elements about local knowledge, clinical expertise, and the enabling relationship with individuals, families and communities, which feels like that's at the heart of what primary care is. It's about enabling people, individuals, working in family groups, communities, to live well. And that's at the heart of primary care.
I'd say, slightly disingenuous, my reflex response is the first thing to say is emergency departments aren't primary care, but actually being pragmatic, the reality is that we do know that actually for various parts of the population, it seems to be becoming what they think is primary care. And whatever primary care is perhaps the first place people are going to go with whatever problem they have. That's perhaps the definition. It's going to be their first port of call, wherever that might happen to be. Now, traditionally, we think there's like urgent and non-urgent. So there are some things that might, maybe should be seen in what people think it should be primary care in the health centre building or wherever it might be. But for whatever reason, society and people's attitudes are changing, and they've decided they're going to come to us in the ED in increasing numbers for whatever it is the needs that they need to be met. So I think definitions such as this, from a working definition, they've traditionally been, primary care has been everything at width of a hospital. And that's how most hospital clinicians have got it in their heads. If you say to them, what do you think about primary and secondary care? They'll say, well, we're secondary care, this is primary care. But I think, as I said, if you're going to improve the lots of patients' lives, and also inevitably, you're going to make your own working life easier by doing this. You've got to perhaps realise that those lines have got to blur a wee bit, and perhaps helping patients, empowering patients to make choices and do things perhaps closer to home is perhaps more what primary care is about. Sometimes that's going to start, they're going to be completely at home and stay at home. Sometimes it's going to start somewhere else, but we need to be able to shift it towards them. And, you know, what traditionally was secondary care roles are definitely got a place to play in that. I think personally kind of emergency medicine's kind of in the tide line between the two. So if you think of it like that, the C, well, depending on which one, but the C could be primary care traditionally, and up further on the beaches where secondary care was, and we're somewhere, depending on what's going on, where the moon is, we might be seeing a bit of both.
I think that the problem with the definition of primary care is it comes back to what the people or the public understand. So I recently had a personal experience where I needed, I think, self-managed care is such an important component we're trying to encourage people to have. So I, in my self-managed care, went to my GP to say, I want to go to this service. And he said, absolutely, I'll just write a letter for you. It shouldn't have happened that way. I knew where I needed to go. To my frustration, I didn't realise that a 2-week appointment process. I went on holiday, the letter came in. I came back to find the letter, I phoned, and they said, oh no, you're off the list, you have to go back to your GP. So I fortunately have a GP who allows me to email him, and I said, look, I'm here again. Would you please write that letter again? I was on holiday. Would you do it? That is not the proper use of a GP's time. A GP has a unique contribution to make to primary care. So for the public, they have to understand it's everything, as David said, is not within a hospital-based care. It's actually all of that care in the community, and it is as much a part of voluntary and other services and interagencies as it is about us as healthcare professionals.
Can I just ask, it's about the submission from the Royal College of Emergency Physicians. It talks about the emphasis of funding and health policy priorities should not be either on primary or emergency care, but on the entire health social care service. And it talks about co-location as well, and co-location of services where primary care facilities are located on the same site as emergency departments. It would be interesting to hear your thoughts a wee bit wider on that, because in rural areas that might be quite a challenge as well.
Yeah. So what that's specific, well, more specifically, but if you look at out-of-hours care, so a lot of what we do, again, this is a blurring of what's primary or secondary care, what's primary care in hours and out of hours. Emergency medicine, I'd say at least half our workload is out of hours in terms of the actual volume. Obviously, there's actually more out of hours in the week than there are in hours, but it roughly comes about 50-50. If we look at some things, then we might see, certainly where I work in, working cross-house in Kilmarnock, it's the 4th busiest ED in Scotland, and I'm a full-time ED consultant. And we'd say the majority of our children now arrive in the out-of-hours period. So 65 to 70% of children who come to our emergency department come out with a Monday to Friday 9 to 5 when we've checked that. That's what the populace want to do. That's what they're choosing to do. So when we talk about co-location, what the Royal College of Emergency Medicine is kind of meaning, and this is exactly what Professor Sir Lewis Ritchie alluded to in his report about out-of-hours care, which I think certainly 2, 3, 4 years ago, is people, there may be some advantages to having everything on the same site. So if people come into where the door is open, which is the emergency department, they know their learned behaviour is that you can rock up there at any time of day or night and something will happen. It might not necessarily be the best thing, but you'll get something. Is having other services available there as well. So let's say, not necessarily part of the emergency department. In fact, I would absolutely stress, absolutely not part of the emergency department. But having, let's say, GP out of hours on the same site, like they have in Grampian, which is a very good model. Or how it used to be in Glasgow when I trained there. You'd have, GEMS would be in a different, in the outpatient, but you could to refer patients to each other, having mental health there, having some kind of social work or single point of contact for frailty, allied health professionals, etc., in the same place, it makes it much easier. In some ways, there is an attraction. So the services all on one site, they can coordinate, they can speak to each other, Or they might be able to say, actually, you don't need to come up because I've just spoken to somebody else and they're going to come out and see you. That's, again, information sharing. And these sort of things are real challenges that kind of alluded to, IT, different communication systems. So when we talk of co-location, what we're talking about is having your out-of-hours care as much as possible on the same site, so that if somebody comes, they don't necessarily need to come to emergency department, the service that they require is there and they don't have to go to another site which may be remote 3 or 4 miles. And all the transport forms that creates. So I do understand for remote and rural, there might be some issues if you've got somebody who's 60 or 70 miles, but certainly within the central belt, most of the distances talked about are kind of, there's an attraction to it. And it's only perhaps people's, what they've grown up being used to, having things within walking distance makes it difficult. I've got friends who live in the south of England, and they think it's totally normal to have their neighbour's hospital more than half an hour away. And whereas people in Glasgow would think that's the worst thing in the entire world.
It's interesting because every other witness, or maybe I shouldn't exaggerate, the general trend of evidence we have heard is to move services away from hospital into the community. The implication of what you're saying would appear to be the reverse.
Well, within certain things, so GP out of hours is one thing. That's kind of what we mainly mean, and it depends. But there are going to be coordination spaces for these people who are not working in the centre but are there, having them close to where people are accessing services. From us, we think that conveys some advantages. And that's just echoing what Professor Salusa-Ritchie said as well. So the casual people doing the job might not be anywhere near there, but there may be people saying, right, we're the ones who are organising who's been done and what's happening. So the communication between services is much easier because you're all in the same building.
Teresa.
I think I said earlier on, I'm always concerned when we always focus on the building, but I do understand David's point. Because I went to visit where they have done that, and I could see where they thought, okay, again, it comes back to doors, doesn't it? One door, go out and go back to the other door. But I am concerned about the mileage that would mean and the transport that would mean for people who are in remote and rural areas. I would be 30 miles to drive to where my actual A&E would be, not actually where my more community-based service would only be 10 miles from where I live. So I think we need to remember about how we're, again, trying to change the public to think what services is the right service for them to go to. That's where we're not doing enough, which actually would help. Also, there's the role of NHS24 to help guide people to go to where the right services are. But I do understand why they feel that, because the onslaught of people coming to the out of hours to A&E is often because they've not been able to access the services within the 24-hour period of the daytime service.
Can I likewise pick up on a phrase from one of the submissions, which was from the Queen's Nursing Institute Scotland, and the comment in your submission that the challenge is to go beyond cooperation towards genuine collaboration and integration. Would you like to expand on that?
Thank you.
Say
yes.
how that fits into this area we're discussing of the definition of primary care and the scope of primary care.
And I think we're beginning to get there in terms of the cooperation, but I think, as we heard from the previous panel, the challenges around IT continue to vex us all in terms of making sure that collaboration could really help. I think some of the conversations, again, that we're having earlier about practitioners being able to refer to one another. So actually, it doesn't matter who you have your first conversation with, that any of the team can then connect you to the person you really need to be having the conversation with, or to be informed and supported by another around the information they need. So it's actually working together much more fully rather than handing off. Actually, I'm not the right person, you need to speak to that person. But actually, if you've got the relationship with somebody, it may well be that you're the right person to take that conversation forward. But that's why you need the real collaboration of the team supporting the right person in the right moment to be accompanying an individual or a family through a moment of crisis, then perhaps to the point at which they can engage with wider services on the next stop to recovery and rehabilitation. So I think it is about, at the moment, the fact that people have different employers, different agencies, it can sometimes get in the way. And I think the cooperation is getting better, but real collaboration will require us to look much more systemically at some of the things that hinder a seamless journey for individuals who access the services.
All right, thank you. I'll just pick up and move on a wee bit as well. I asked the last panel about variation in employment status, so this probably would be directly related to the fact that GPs are independent practitioners, they employ their own staff, but now we're putting National Health Service employees within those buildings, behind those doors. So do you have any idea or thoughts on what challenges that might produce when we've got different employees reporting to different levels within a chain of command?
Teresa Farr.
I think that when we talk about workforce, integrated workforce, we're talking about a workforce for integration. So it's how a workforce works with whatever way the service provides, whether that be in an integrated system or within actually, as we described, within the general practice. You haven't got enough building. The size of the building could never employ all the staff that actually require to work in a multidisciplinary, multi-agency way provide services. So we have a tendency to go to particular roles and bring them into the building and employ them, but actually the way of working that has to happen is how to work with those teams across that way in the collaborative way Claire has described. It is not possible to have one workforce employed completely by one. If you did that, then how do you work differently with the voluntary sector? How do you work differently with the other services? So I think it's about a different approach to it. It is possible, and then we've recognised this as a college ourselves, that when we talk about integrated workforce, it is possible that there may be places where we think, you know what, being employed by one team is the right way to go forward. But our work has shown that if you have the right ways of working in, if you've got the right principles of what you're trying to achieve, and you've got the common goal, you actually can work as a team together, focused on that. We gave evidence when we set up, when the whole integration came about, we actually interviewed integrated teams who were line managed by different people, but they were very clear about what their focus and what their outcome was. But there probably is a place for that within some teams, but I don't see that within primary care, because you couldn't possibly have them all in one building to make that work.
And I guess if there are challenges out there, what can be done then to mitigate some of these challenges?
Well, we've had to spend a lot of time debating with the RCGP and with BMA over district nursing. And district nursing is actually one of the most important roles within the 24-hour service for a GP practice and for other services. And so a lot of time was spent saying district nurses needed to be, actually based within a GP practice, but given their mileage and their coverage of their care and patients they had to see, it wasn't possible. So there has been very successful ways of working with district nursing within GP practice, but it does come back to the point I made earlier about access. That's why we called for access, which is technology, multidisciplinary record sharing, means of accessing the same technology and remembering that the person is actually who holds the record is the important person in this and how you work there. So it's about working without walls. It's about working differently, and I believe that that's happening for district nursing without having to be. So and sometimes it's alignment, sometimes it's not, but it's actually not been employed or based there, and yet we deliver those services very successfully across Scotland at the moment.
Thank you very much. David John.
What you're kind of referring to really is a more general sort of issue of how if people working in silos and silo culture. So, you could say there's lots of people working with exactly the same employer, perhaps even the same managers who are quite happy to have silos and not talk to each other or cooperate depending. Some of that boils down to leadership. I think it's about what people see their roles are. So if there's a shared vision and people are happy that the jobs have been defined and they're all working to the same goal, then it need not matter at all. So, we can... Our work cuts across many different line managers, shall it be, and some of them are very good, and I'll be honest, and some of them maybe not so good, and it depends. It's not the fact that they are managed or the salary comes from a certain place or resource is not really the issue. It's whether they see the role they're doing as their job or not, and that's perhaps is important to work out. So if you've got somebody who's a more negative experience might be where people are going to have a very prescribed definition about their job and don't want phoning unless it's what they say it is, versus other people who are happy to say, well, actually, that I can help you with this, and you might need to speak to somebody else. That's just human nature. I don't think who employs you is going to have a lot of bearing directly on that as opposed to local cultures and leadership.
And you mentioned leadership, and obviously effective leadership, whoever is leading a team, whether it is a nurse leading a team or paramedics leading a team or whatever, that's really important to continue to invest in leadership.
Claire Carroll.
And I think it's that collective leadership. How is it that we invest in the skills for people to lead across systems and across teams? So it's not about hierarchy, but about people's ability to coordinate and influence across quite complex landscapes. And I think that is a slightly different skill set that people have perhaps traditionally developed under the banner of leadership, and I think it's being thoughtful about the skills that people need going forward to ensure that they are able to coordinate care for individuals and families and have the authority to be able to do that even when the services and interventions that are required are not delivered by the same employer or the same system within which they work.
A brief supplementary, Brian.
Yeah, I'll thank you. I'll take that just now. I think I was just listening to what the panel was saying there, and I was wondering whether or not we talked about, now E&E's being thrown into this, sort of a mix of primary care. We're talking about GPs, we're talking about nurses, and all the variations within that, midwives, all the AHP disciplines. I'm just wondering. We hear of a crisis in all of those. The language that's being used is a crisis across all of that. And I wonder if there's a tension between the disciplines in terms of almost a protectionism around trying to ring fence their investment and sort of protecting your own disciplines. We heard that today in the earlier panel just now. Is there a tension developing here around, who should be involved in a multidisciplinary team?
Teresa Fife.
I wouldn't say so among the disciplines. I think the tension's been played out because workforce planning hasn't actually incorporated that. So you heard my colleagues before saying, and they're right, there's never been clear evidence of workforce planning for allied health professions or actually clearly saying how we've done that. But remember, this committee was part of the work around the passing of the Health and Care Staffing Scotland Act, which is multidisciplinary, and the workforce planning in there is intended to be multidisciplinary, not doing doing one tool, one methodology for one multidisciplinary team, unique tools, but also like having a multidisciplinary toolbox where actually you say, so there's a commitment within there. The tension comes when naturally, as they referred to, there's a thought that only the public think that there's only doctors and nurses, and that gets played out. Whereas in my view, and our commitment to the multidisciplinary has been clear we were one of the instigators with the RCGP of having that primary care professionals group, because we believed that by working together, we would actually understand better what our unique contribution was, where we actually could share common working, and that was around access, around technology, around all these other points that we wanted in our call for public. So I think the tension's been more played by how that is portrayed both within the media, but also the absence of multidisciplinary workforce planning in the correct way.
One of the things we've heard from social care staff is concern about the communication between district nursing and social care. Is that part of what needs to be resolved?
I would agree, because actually it's exactly what David said, that if the ways of working have been that one group is siloed to work a particular way, but the chief nurse led a working group on transforming roles, which we were, as a college, were party to. And that the role of district nursing now has been stated very clearly about how they are that linchpin within 24-hour care, because that's what they are, but actually how they actually have a responsibility to engage and work with all the other parts of the service. Some of that's about sadly about different technologies, different records, different ways. But putting everything into a building doesn't change that. The way to change it is be clear about what those expectations of a team is and where they should be liaising with social care and others. Some of that tension that is going on, sadly, is that it's about whether something is social care entirely, and yet we have made a decision in Scotland to actually say that people are discharged from hospital care to the community and primary care with complex health needs. So that's where some of the tension comes about saying it's either social care or it's health. The whole point of health and social care integration was to actually recognise that you needed both arms in order to deliver that for care, and we would be committed to that.
Okay, thank you very much. George Adam.
Thank you, Convener. Good morning. One of the things I was talking about earlier on with the previous panel was how do we get to that cultural change, because we've all been talking about it for a while now. You know, I might just be getting old and grumpy, or older and grumpier.
Certainly grumpy.
But basically, how do we get to the stage where, you know, if you look at the example, similar to what David brought up earlier on, it's Friday evening, it's 5 o'clock, or it's after 5, something goes wrong. Currently the culture for an individual will be the GP's shut, social work shut about 3 hours ago, and effectively they will rock up at A&E, and A&E will have to deal with all these situations. Now that's a very broad and very basic example, but how do we get that culture change to be able to move further forward?
David Chung and then
well, I'd say, first of all, I think out of hours primary care, so I'm not saying out of hours GP, although out of hours GP is a large part of that, has got a role to play here, which is probably being underused for a variety of reasons. Again, public perception, I still meet people who swear blind they had no idea there was an out of hours GP, you know, of all ages. I think, and they've got their own challenges. They've got issues with you know, trying to maintain their staffing in the face of some severe challenges. But you know, it's again, and so if you talk about that, having some ability when people do rock up to say, actually, you're in the wrong place, but you need to be in place X. So that's when we talk about co-location. Someone like Grampian, a GP will meet you and go, do you know what, you need an out-of-hours GP, and here we go. So that's that example of how it works. I do accept geographically it can be a problem. Also being able to signpost to people say, well, actually, we can't see you, but do you know what, someone can see you tomorrow. So for very many sort of social and mental health things, what we've provided by default is a sort of safety net for all manner of things, whether it's individual themselves or it's another agency who goes, well, we're shut now, but any problems, just go to A&E. You know, patients tell us they've been told it all the time. I'm not sure I always believe them, I'm not that naive, but there's certainly a culture going out. So it's been able to say, well, actually, you don't need to be seen today. What you've got is safe. If you phone this place, they'll arrange for someone to come and see you tomorrow, or to access, let's say, your optician tomorrow, or all these, you know, good services we've got. There's definitely been progress of people seeing the right professional at the right time. So that's it's pathways. It's been alluded to before, bit of IT again, but I think culturally, when people learn, and this is how it's going to work. Human experience is learned and taught and shared, mainly by word of mouth, whether that word of mouth be face to face or whether it be on social media. That's how things are done. So if somebody said, well, do you know what, actually, see if you go to Crosshouse with your kid, it's great, fantastic, that's it, the word's out. Whereas if it's, well, see, actually, we went there, but actually we saw the GP instead, they were miles better. Or I went up there, but then I realised I could actually just, you know, go on this app and then get seen the next day. This is how the behaviour has to change. There needs to be a better way. People have got to learn that it's better rather than being told it's better. So the services need to be there and then they need to be accessible, and that will help. But that's going to take a little while.
The integrated teams and communities recognise particularly that Friday evening, and so they often have services running to 8 and 9 o'clock at night. But this comes back to, for us, for district nursing, because we would have the aspiration that district nursing would move to a 24/7 service. So we worked with the government up to 2018 last year on the requirements for district nursing, only to stand still, not to actually have that 24/7 model where you do have access to services. And we are here now in 2019 with no commitment to that work, no announcement of the investment, yet we do know we've actually got a 6.5% vacancy, and we have a 60% numbers of district nurses who are at 55 and 60, which we all know that means they're going to go from the service. So sometimes in the planning, we come back to workforce planning and that commitment to that, we're not understanding how do you provide that service that people would know. Again, it comes back to how they know that they could access community services up to 8 o'clock on a Friday evening that they normally would believe would have ended at 4 or 5. And actually there's also about then that whole picture about what is how you model that service. And I agree with David where there's different ways you can use technology, but of course there are people who don't use technology well, and that's one of the challenges. But where you can use technology and educate and encourage those who do wish to use that, to use models that actually allow them to get appointments. I am somebody who make my appointments that way entirely. I also would use any service that's available to me when I'm travelling, airport community pharmacy, you know, whatever, high street pharmacy. But again, it's not in the nature of people to think that way. And that's what we've got to change, is to say, if you have an eye problem, why would you go to your GP? You go to your ophthalmologist. But that is not known by most of the public until someone does it and says to them, I went to the ophthalmologist and they gave me the best advice I ever could have got. But unfortunately, we're still promoting a traditional model, and that's going back to your question, Brian. The media presents a traditional model, and when we talk about gatekeepers, that's the traditional model of the way it was for GP services. It has now got to be different. We have to think differently, but we've actually got to help the public to understand that that's how services are going to be delivered.
Claire Cable.
I think the other cultural shift is to a more anticipatory model of care. So we have, the Scottish Government spent a lot of time looking at the NUCA model from Alaska and the House of Care model, and those sorts of models feel like an important thing to invest in and sustain, because when people are empowered and enabled to take more responsibility for their own health and really become experts in their own health, then those anticipatory conversations happen in a timely way, and hopefully not at 4 o'clock on Friday, because there's more understanding of what it is that individuals need to stay well and the steps they might take if they begin to experience deterioration. So I think the cultural shift is also about that continuous shift to realistic medicine, self-management, and the kinds of models of primary care that enable that better, so that anticipatory care becomes the norm in every conversation, so that people feel better equipped to deal with health deteriorations or crises when they happen, and know where to go. But I think those anticipatory conversations have to become core. I think they are in places, but we still haven't quite given people the time to have those conversations well.
Carry on.
Yeah. Part of the cultural change, and it's in the back of what Claire said as well, is that for managing long-term conditions, I mentioned my wife with multiple sclerosis now, she can work her way through the system and deal with that, but there's others that can't. And one of the things is, like, she would go to her MS nurse rather than her GP, because the MS nurse, well, Stacey knows more than the GP probably about MS, you know, and than the MS nurse. So it's how do we get people into that place where they're empowered, they feel they can do it, and also how do we ensure, what is your role in all this to ensure that we can push this agenda forward and make sure that people are empowered, that they literally, as Teresa says, they decide, they take your attitude and they just go forward that way, because many folk don't. The first thing is GP.
David Chung.
I'd say we've been thinking about definitions of primary care and listening to some of the things around the room, and I think it's perhaps also implicit in people's minds, whether it's unconsciously or not, is that primary care is seen as Monday to Friday 9 to 5. So we're talking about various issues. Most people, there is certainly a situation where people have planned issues that they can deal with, but a lot of, certainly what we'll do, people aren't planning for their child to be unwell that day, or for an acute flare-up of their chronic condition, or these sorts of things. And trying to access the advice or the help they need, as we've said, out on 5 o'clock on a Friday is when these things tend to happen, is a difficulty. So perhaps in some ways, it's not about location, but it's also about timing. And we talked about district nurses being fundamentals, the accessibility of services is part of what primary care is seen to be or not to be. And maybe that needs to evolve a wee bit. You know, I say evolve, but you could argue 30 years ago, GPs were providing primary care, but perhaps in an unsustainable way. But it was a different model. People being able to access the advice, the support they need out with a Monday to Friday 9 to 5 may well mean that actually, as a whole, we end up working less because we deal with problems in a timely manner. Things don't get worse. Backlogs aren't created, and actually, the people who are doing the job, whilst they perceive it being more onerous, actually, like I have found in my work life, I'm doing accident emergency for 20 years now, my work-life balance is the best it's ever been. And I keep trying to say to people that. So working more weekends, working more evenings, is actually my working life is better. My patient schedule is better. But as a whole, in society and within medicine especially, there seems to have been this paradigm shift to 9 to 5 is the only way to go, and it's kind of bound up in your identity. I think primary care does need to move a bit beyond that, and people need to, within the profession, need to see that their lives will be better as well as their patients if they blur things a little bit more. Maybe not 7 days, maybe Monday to Friday, 12 hours a day, but still doing that will make things easier, I think.
Thank you very much. David Stewart.
Thank you, Convener. Can I talk about workforce planning? Some of that's been touched on already. And clearly that's vital to sustainability of primary care. Can you talk about workforce planning in your own occupations and how satisfied you are with that?
Teresa Fife.
Well, obviously, workforce planning, as I say, is an integral component of when the implementation of the safe staffing legislation is brought forward. And we worked hard with yourselves and others to be clear that if we don't get workforce planning right, we're never going to get out of this cycle of, as a colleague said earlier, crisis management with the workforce. It comes back to being clear about what tools and methodology you use to assess workforce planning. And I heard earlier a discussion about the difference between what the boards might report to what actually is required, which a few years ago we went through a period where workforce planning was entirely designed by what you could afford. And then in fact numbers that were turned were based on this is what we can only afford, not what we need. And the government had to take a call for us for nursing on nursing numbers based on that data. What we're saying now in the district nursing modelling that we did in collaboration with the government was the best modelling we've ever seen done. And it was a new model working with data sets from across the whole of the government health department. It was absolutely superb, brought it together and came out with a model for district nursing that was a growth model, allowing us to stand still, as I said, not necessarily to aspire to the full 24-hour service, which is where we believe it needs to go to for the public to be able to access services. And that modelling is for us a future way of going forward. And we've said that should happen, for example, in the issues they've got with mental health nursing right now, around CAM services, they would understand better. So the issue is, how do you do multidisciplinary workforce planning, and how do you get methodologies and tools that identify the unique contribution? And my final point is, nursing is the 24-hour service. So when you're measuring workload, you have to measure the 24-hour service for nursing, where you have to measure the different interventions for the different professions, which might be for different periods of the day. That's the challenge of getting, and unfortunately at the moment there seems to be a belief that you can do one tool to measure 24-hour services as well as the different interventions that are necessary by, say, physios or OTs or dietitians. That's not possible to do it that way. You need to do a multidisciplinary approach to workforce planning. Do your methodologies per professional group. Where there is collaboration and shared working, you can build that in and recognise and actually build up your workforce planning in such a way. And that's how I'd like to see it going forward. But we're not in a good place on workforce planning at the moment.
I think that's, through your convener, I think that's very insightful comments. In general sense, it's about what you can't plan if you can't measure it. And obviously, we also have to recognise, particularly in nursing, the scale of the workforce. I remember years ago when John Reid was Secretary of State for Health in Westminster, when he took over, he said there's more people employed in the Red Army and the Indian Rail Force, which I thought was quite an interesting point. I'm not sure there's anything we can learn from the Red Army in terms of workforce management, but it's a huge scale of operation, isn't it? And we heard earlier about the ISD dashboard. There were some issues about how accurate that was for other occupations.
The triangulation of the data we used in that modelling with the district nursing helped counter that out. So it was actually using a number of data sets and then applying that to a modelling, which actually helped get us a growth model that we required. So it is, and it was actually bringing all those data sets together. They were delighted to be in the same room together, because those who are generating that data want their data to make an impact on what they're doing. But we've got very stuck in our workforce planning model, which actually has tended to be, again, quite traditional. Unfortunately, it's played out, which is where your comment, Brian, with regard to then disciplines looking like they're fighting over the same pot of money, is actually true. And there's a feeling then that nursing, and we would say nursing, which is 20% of the workforce in the NHS and the community, is nursing, And yet we have shifted a significant amount of complex care to the community, but we've had no significant change in the workforce in the community, which was the point of that district nursing model. So it's actually about understanding what is our goals and what we wish to get to, and develop workforce planning methodologies that enables us to actually be clearer about the planning, and then have the debate about what we can afford and can't afford, not determining it from the start about what the financial balance is. I'm afraid it's not a good way to go forward.
Okay. David Chung.
So I've alluded to silos now. I say medical workforce planning is a somewhat opaque process. I've been just about within about 2 years, I think, got to a point where I might have a clue what's going on, which should tell you probably all you need to know about how clever a process it is. But there do appear to be different silos with different goals, different needs, and different sort of dynamics. So you've, on the one hand, anybody with common sense would go, surely we should work out what our service needs are to create a safer, sustainable service for patients and staff. And as Teresa said, perhaps, okay, not think about the money to start with, but work out what we need to make sure everybody's got what they need. What services are essential, what are we going to provide? But unfortunately, we've divided up service and training. So NHS Education for Scotland can say, we'll give you this many doctors for training, and training is the thing that we're interested in. We're not interested in service provision. Potentially, we are, but that isn't our main goal. And service is left individually to each individual health board, hospital, such like. Whereas one would think you could certainly have a look at the whole big picture, and they influence each other. If you have a department which isn't well staffed enough, the training is going to be rubbish. Which may be why you might see in GMC surveys or things like this, cultures, places under strain, are going to give perhaps a poor survey. In Scotland, I'm able to say with some pride that emergency medicine departments in Scotland have scored, I think, 4 out of the top 10 are in Scotland for trainee satisfaction. But that's not the same for other specialties and other hospitals. I mean, that's because we have this lack of of coordination between the two. So they shouldn't be divorced. There should perhaps be greater input than the slightly might be careful what I say, but it's difficult. Let's say for me as a chair of the Scottish Board of the College of Emergency Medicine, it's taken me a good while to find out how do we influence, being able to say what we think the number of emergency medicine doctors, both in training and consultant, should be. Those processes are difficult to understand, and it's not just myself. Other college heads have said the same. So whatever bodies and organisations which are involved at the moment certainly could be better served, and Scotland could be better served by having greater coordination input from what's happening just now.
Okay, thank you very much.
Thank you.
Claire Cable.
Just to add, the Royal College of Nursing have done fantastic work around this, but the other group that you might want to be thoughtful about is the nurses who don't work in the NHS. So workforce planning in government has tended to focus on NHS workforce planning, but in the way in which we have defined primary care, we are talking about a wider workforce and being thoughtful about the nursing staff who work in social care, but nursing staff who work in care homes, in occupational health nursing, all of whom have a vital role to play in primary care, but don't necessarily. Now, care home nursing, Scottish Government and Royal College of Nursing have done a significant work on, but just so that as a committee you're thoughtful that it's not just about NHS workforce planning, it's broader than that as we're thinking about primary care in the round.
Okay, thank you very much.
And my final question, I'll keep it short, I'm conscious of time. How important then is the role of staff in planning and evaluating new models of care?
Teresa Fife.
I think the staff, but I think the people. So if you actually, I think a comment was made about if you have a particular condition, long-term condition, you know your actual care better often than actually other people do. So I believe it's about actually staff being engaged, and there is a lot of work going on around pathways for patients where actually staff would be engaged within that. I think, though, perhaps again it comes back to who and how that voice is heard for all the different disciplines and thinking that way. So there is examples of very good multidisciplinary team working around actually the planning of care and the planning of pathways. I think you mentioned diabetes earlier on, David, and that's a really good example of where that transfer of that service to a different model has come from disciplines working together. The same within cancer services. So it seems to be easier when you've actually got a long-term condition or a particular service that's actually very, it's clear, its boundaries are clear. It's the provision of other services that are different models that's probably a lot more harder to get right, because it's not always possible to be clear. It's not visible who else is needed to be in that picture. So for us, for example, if you change the model to around pharmacy, my focus for years had only been on pharmacy within hospitals. Now I would understand fully how you would need to engage with pharmacy in the high street, pharmacy within communities, different way of looking at it. So it is, sometimes we're very set in how we set the pathway, and Claire's point's absolutely right. We then often don't pay enough attention to the provision of services within the care home sector and those who provide services within that integrated space that might not be captured so well because they're actually within a different model. So the integrated health and social care space is a new way of thinking, and I think we've not yet caught up with how to capture that into our planning and sharing within there.
Thank you very much. Oh, David Chung.
I would say so. One of the things I really like about the role I'm in just now is that I've had to come to various and very good Scottish Government initiatives about things like primary care out of hours, 4-day weekends and such like. That's put me in a room with people I've not met before, who I then speak to and then find out about other things I didn't know about. And I'm sure, as I said, that's happening on a national scale. So for me as a college VP, it is my role to try and, on a college level, at higher level, speak to people, find out ways of working together. But that could be replicated on a more local level as well, as you said, with integration. And in some ways, whilst the integration agenda is absolutely the right way to go, and we're seeing great examples of that, it's uniformly, well, it's not uniform. So I think locally, being in the room with people, you become aware of what services were around that you never knew about. And if you just stay in your silo, come back to this again, you're not going to be aware. So in terms of workforce planning, I want to be quite clear. I think a lot of the workforce planning that will benefit emergency medicine is not actually going to be in emergency medicine. I'm perhaps unique among other people, I've heard say, perhaps a very bad college vice president for saying that. But in terms of what affects us more, it's things perhaps happening in the community in primary care more than anything, because crowded emergency departments are very often usually caused by what we call exit block, which is actually going all the way down to issues within social care and ways people work. So bringing people to hospital as a safety net when in fact we should be assessing them in their own home in a much better way. These are all ways we've got to work in a different way, and you need the disparate people in the room together, whether that be locally or nationally, to understand what they're doing, because if they're stuck in their own silos, they won't understand that.
Sure. Sandra White.
Well, thank you very much, Convener, and good morning. Perhaps with the coughing, I'm not a great advert for the Health Committee, but obviously the Health Committee have been doing inquiries out with in the communities, and I want to welcome one of the gentlemen here today who's sitting at the back there, who was part of one of the panels, and you have answered some of the questions I was going to ask, but one of the overall questions I wanted to ask is, what is your experience of the public understanding of the need for change, or the change to primary care? Do they still expect to see the GP first as a gatekeeper? And what roles could your professions do in explaining, or do in explaining the fact that things are changing and it's not just acute or secondary, there is a primary care and working in the community as well? So that's like 3 questions, I think.
Who would like to start? Claire Cable?
I think what was really encouraging was the work that this committee did, listening to public perceptions, and actually what came across, as was mentioned in the last session, was a real readiness and openness to be for change, to be seeing different people and the right person. And I think increasingly, as the public experience care given by nurse prescribers and allied health professionals and competent optometrists who are fabulous at in their specialty realm, that shift in attitudes will happen very rapidly. Added to that, the role of technology, and as we had described earlier, those opportunities to find information online and then have it followed up with a face-to-face conversation or a digital conversation of some sort. So I think there is an increasing readiness. But for those who are perhaps older and frail, it's the continuity of relationship that I think is at the heart of this. And that might be with the GP, it might be with the district nurse, it might be with the community mental health nurse. But I think what we need to do is ensure that our workforce planning enables the continuity of relationship for those who need that ongoing enablement and recovery support. So there isn't a one-size-fits-all in this landscape, but whether we're looking at young families who need advice, or whether we're looking at an older person with quite complex long-term needs, I think there is an openness to change.
Thank you. David Chung.
I think, yeah, absolutely what you say. So the challenge is to people are suspicious of changing new things. They've got an experience base, which might be that this is the way you get treated for this. It's very difficult because in one way, you know, a lot of people feel that acute and secondary care hospitals is the safest bit. You know, you hear people say you're in the best place, whereas in fact, it's better that people stay at home, better if they have their mental health needs assessed at home, or all sorts of other things. But people don't, at the moment, they don't believe that, rightly or wrongly, usually wrongly. So you're right, it is about giving them experiences which are better, which will then very rapidly, the pace of education I've noticed within communities can be lightning quick for certain things. Within 6 months, people might know that something's available and that's what they want. And we see this all the time with some things good and bad. So it's been able to give people opportunity to experience a better way. That's the way it's going to happen. You know, otherwise, just telling them it's not going to work.
I believe there is a shift, but I think we're a long way off where we need to be, and that's why we're clear there needs to be more about public engagement. But if you think what practices themselves can do with how they share the information, and my point earlier to you that I have to go back via GP to get a service which actually could have been straightforward referral, that's not going to change the mindset that actually that's not what you need to do. I don't like the idea of what Miles was saying to us about why should you be here. That's not education or training or supporting people. It should be much more about giving the information. These are the services that are available to you, and do you know you could access these services, and this is how you would access them. I see some practices doing that very well. In fact, if you go in, you see signs and posters, information leaflets saying this is what you can do. We have made a shift from what it was, but we've got so much more to do. But it's exactly what David said. It's the learned experience that if you know you don't understand that the building's closed, that's where we see the weak link, and I am now concerned that I don't know where those services are, I will go to the next building, which is the A&E department. I understand that, especially if you're a young mum with a child that's ill, you're thinking, I need to go where I'm going to get the help. So we've got to just improve how the public understand how they would access services in their community and with where they are. But that's done well in some places, but not well, you know, in a way, a consistent way that would help the public to understand. And if the learned experiences, and I was disappointed to see that the generational, which was always said it was older people that didn't get it, so actually younger people are accessing building services as much as. So I was very disappointed to see that, because I thought if we could have anywhere, we could have made the change, it would have been with younger people who would use technology and all of those things well. So there's something going wrong there that they believe rock up to the building is the best way to get my service, and that's not a positive way forward for us.
Obviously, I'm an MSP in Glasgow, and Glasgow Kelvin. I've never saw anything like that in any of the doctor surgeries that I've been in, so I maybe ask Miles which doctor surgery. But you've hit the nail on the head in regards to people still think they've got to, as you said, rock up to their GPs. So is it encompassing on all of the professions, your own professions and the GPs, to be able to signpost these people there, and how it's there, but people can't access it, so they're still going to the GP, who's a gatekeeper. So that is the biggest worry. So how do we get over that? Would you...
Sorry, okay, convener, if I could come back to the gatekeeper does not equate leadership. So the gatekeeper role is the traditional role of the GP. It was such that, in fact, you only went through your GP for all services. And I can recall years ago being at a session where somebody did want to bring back Dr. Finley's, TV programme model. And in fact, it's not the way where our services are today. But leadership, which we equate with gatekeeping, is about leading, working with multidisciplinary teams in enabling those services to be open to people. But the way we use the language and the way the language comes out to the public, I would understand why they think I can only see a GP when we just talk about a GP. Now, a GP has its own unique contribution, firmly believe in that, to the multidisciplinary team. But if we actually are talking about the team in a way, and people, when they experience that, change their mindset, and in fact that can be across the generations, they can fully understand, but we need to invest in a public information sharing model that actually gets out there and really shows people what the services are, where they could go. But we have got to remove the concept that leadership means you've got to go through a GP to get that bit of paper to get to the next service. That for me was a real shock. I would have believed personally that I, as a self-managed person, could have enabled myself get into that service, and when I realised I couldn't, I was gutted, to be honest, because I thought if that's the message, then that's not getting it right.
Okay, thank you very much. Brief supplementary, Emma Harper.
Yep. Teresa, you mentioned that that we haven't caught up, so change needs to happen. We quite often hear about how slow IGB integration is, and I know transformational change is really hard for folk. And the Royal College of GPs have called for a national education programme to make folk aware of what change is being proposed. So do we need to tell folk to hurry up and just get on with it, or do we need to be a wee bit more patient and then support engagement like the RCGP are calling for to train folk?
I think there's different elements of it. So the primary care professionals group, which RCGP is a part of, we're very clear we need a public engagement model, and you can do that through education. You can do that through sharing of information. If you give someone the right information, they don't need education. If it's actually very clear, this is how I access that service, people do follow through and think, well, I need that done, so I'm going to go there. So I firmly believe it's a different number of models you might want to do. But it is also about, it comes back to when we say, so if you took Programme for Government, which came out, it talked about a number of elements that were going to be looked at, and it only referred to GPs as actually needed. We know we need district nurses, weren't even mentioned. My HB colleagues would probably say they feel exactly the same way. So we keep perpetuating to the public that actually, and as I say, please let me be clear, I firmly believe in that unique role of the GP, and you need it within the team. But we keep presenting it like that. It's like saying that actually you only need to go to see a consultant for your access to hospital. Years ago, a number of models were developed about enabling GPs to get people into hospital and accessing different ways of getting that decision-making made. So we're forging ahead on advanced clinical decision-making by other professionals. We're forging ahead on MDT working, but somewhere we're trailing behind in actually bringing the public with us in understanding what we're trying to do. And I do believe we need a concerted effort on that if we're ever going to realise this change.
Claire Cable and then David Chung.
And I think it's about taking that engagement about a stage further. Of course, it's about education, and that's really important, but it's also about co-production. It's also about saying, where is it that people wish to access those conversations? And there may be young people who don't feel comfortable to attend a GP practice, but they would like to access healthcare advice elsewhere. So if we've got primary care professionals, whether they're school nurses or looked after children's nurses, they need to be able to refer directly to others and to signpost young people without having to go, via a GP. Or so in the principles that we put together in the vision, that was very clear that ability to refer professional to professional was key. So if we're looking at engagement more widely and thinking about where it is that people would wish to access those health conversations, then again, we need to be thinking, differently about the way in which we give information, but also enable people to be directed to a range of services from different starting points.
David John.
One thing we know is that in terms of who attends in most departments, the sort of 17 to 35-year-old group has always been numerically the biggest. And that's getting bigger. So what you're saying is it's not necessarily lots of older people, although they've been admitted to hospital more, but they're not necessarily attending in most departments more. So it's, you're right, it's young adults or youngish adults are coming to us, possibly I said, because they're deciding they want to come to us for primary care issues. And we're saying, we're not trained to do this, we're going to give you a bad service. But to them, well, I don't know exactly. This is perhaps a thing. Should we be asking them, why are you going there? What's the most important thing to you? Is it accessibility or is it expertise? What's your perception? And the other one we know also is children 0 to 4 are also another big growth area. But that's also, we're kind of responsible for that because we've told people, you know, sepsis campaigns, all this sort of, so we've just got to live with that. And that's what we're going to have to do. But I do think that the younger adults are, a lot of that is also mental health as well, when you break it down. So these are things we perhaps need to say, where are your needs? Why do you want to choose this? And shouldn't we do it in a better way? What would suit you better?
Thank you very much. And finally, David Torrance.
Information sharing and governance and the barriers that are there, how is that affecting primary care? And what could professionals do themselves to mitigate some of the problems?
Yeah, I think that, again, going back to our primary care professionals, that was one of our first areas of work was about access and, in fact, ensuring that the record that is there, which is actually the person's record, is actually able to be accessed by all the disciplines who are required to, and how you work there. There was a barrier to that because traditionally it had always been only within the medical team that actually accessed, and there was a concern about how you manage that access for other disciplines. The barrier at the moment is actually, well, there's working on within NEST to try and actually get towards the technology that would allow that access to happen, and that is one of the, until we get that. But the other issue will be is that if we fully respect, that's what Claire referred to earlier about collaborative, if we fully respect the fact that each discipline that has a part of that person's journey can access that record and provide that information, then we actually improve that. That was not a difficult commitment. What was more difficult was getting the people who were developing those models who were stuck in thinking it only was one way, or concerned that one discipline was going to be unhappy at their particular model being taken away. So that was one of the first, because obviously there was a lot of investment in technology for GP practices, but absolutely, very, very poor development around digital technology, say for district nurses and others. It was almost like they've sorted out there and then not get it right for all the others. So it is that looking at it that whole way, though I do believe that the work stream that's within NEST is trying to do that now, but I think the barrier will be persuading people to give up something that they have fought hard to get and feel that they're not convinced what they're going to be given will do it right for them, because that's often what happens around technology, is people get very hung up on whether it works for them. But I firmly believe it's the only way we can go forward is to enable people to access, give the information correctly, let people out on the road, because remember community services are out on the road, be able to get to use digital technology to get the information very quickly back to the GP practice without driving 30 miles, which some are doing, to go back to our computer point to get the information. That timely access of information out there in the road could make all the difference to the very issue David's referred to. If you can get the services right, people might get what they require in hours, rather than somebody later picking up that message and thinking, if I'd only known that new prescription, changed their prescription, something that actually would make the difference to care. I think if the people see that, I don't think they will be as concerned about access as different professional groups have been.
Okay. David, do you have any?
No,
thank you. Thank you very much. Miles, please.
Thank you. I wanted to try to pull some of the themes together around what was the government's 2020 vision, and we have a year before I suppose we can judge whether or not that's been achieved, and I just wondered what your opinion is, given the challenges that set and trying to change services really. Do you think we've achieved that?
Claire Cable.
I would say we have a way to go in terms of being truly visionary, as I think the vision set out. that the reality is not going to be that different in 12 months' time. And I think it's what Teresa mentioned earlier about the resourcing. You know, that vision that more care would be provided close to home has not been matched with the resources to support care closer to home. And that, I think, I don't think that's going to change in 12 months. But the other part of their vision is that real emphasis on primary prevention, secondary prevention, anticipatory care to prevent some of the untimely hospital admissions that continue to happen.
Okay. David Chung.
So I'd say there is examples of good practice which probably would say these things do in that particular area correspond to what the vision is, but the challenge has been trying to do that uniformly in every area. And I think that perhaps is something, it's quite a common thing you see. There's a very good policy document. The aims are entirely appropriate. They've been produced in consultation with professionals as opposed to, let's say, someone from Deloitte or KPMG. But then it kind of fades away a little bit. So I think that's a real challenge to say, we've got 12 months left. These areas are doing it. Perhaps challenging people a bit more and say, why isn't your area doing it? Because everywhere does have the same resource issues. And some places are doing it within a resource envelope, which is similar to somewhere else. But that's tricky. If you look at the NHS plan for long-term plan for England, it does specify things which you could go, oh yes, that's just what we're doing in Scotland. But the thing it does that's different is it says if someone doesn't do this in 18 months, someone's going to get asked a very hard question, which might mean they lose their job. But that's probably the most controversial thing I've said in this chamber today. But we should be maybe asking the question, if some places can do it, what have they done? What can other places learn to make it happen there?
Thank you very much. Teresa Farr.
I think if you go back to the Health and Care Staffing Act, those of you around the table here know how hard we had to work to open that up to care homes, which actually told me that we hadn't changed our thinking. We're happy to shift people from hospital with health needs to care homes and still refer to it as a social care model. And yet we have people there with the most complex health needs I've ever seen and being provided with significant, amazing care. But that was a hard struggle because we have an NHS model in our head still. And I would say that despite working with integration of health and social care, I don't see evidence that in fact some of that has changed in some areas. I, like David and Claire, would agree that there are models of practice, but one of the frustrating things for primary care was the Primary Care Development Fund. So they had an approach that put out money and almost like throwing out seeds for lots of flowers. And out of that, innovation would come. Now, the evaluation of that shown is that you can get good models tested, but they don't sustainably get implemented. So why is that? So, you know, I would have preferred that the primary care funding had actually identified 2 or 3 key areas and said they must be sustainable and in fact invest in a way that drove change rather than doing what I call the flower seed showing, which actually hasn't converted to real change. Yeah. I wouldn't be with David where I would want people sacked for what they do, but given that, given that I'm a trade union, but I would be of the view that there should have been clear asks of why have we not shifted that change. I said to you that is only the nursing workforce is 20% of NHS Scotland's workforce in the community. Ask yourself how much of the care have we shifted to the community, and yet we haven't considered that we needed to have an increase in district nursing and other school nurses, practice nurses and others. Yeah. I would say that's a testament of not actually following through with a vision. But it's, thank you.
Thank you very much.
And on that specific point, you know, the real challenge, to sum up both panels really, is boots on the ground to do this work for people to access the right healthcare professional. Now, given we've had 3 versions of a national workforce plan put forward and being developed, do you have confidence that that's actually going to meet the challenges which we've been talking about today?
Very, very brief answers, if I may require.
A brief example that I think is a sort of seeds of hope. In NHS Fife, they have a team of advanced nurse practitioners who are doing weekly ward rounds, or care home rounds in every care home in Kirkcaldy in trying to support people's care in a homely setting. And that feels like a really good example of where investment is being made in the right place to keep people in a homely setting.
David John.
The Scottish Academy of Medical Royal Colleges is working on workforce planning as we speak. A document will be coming out soon. If not, they will have a number of recommendations. And then I would say, listen to them, us. The fact that perhaps they're feeling their voice hasn't been heard is a wee bit telling in terms of where you would take medical workforce planning.
Thank you very much. Teresa Fife.
I would say it was a tough order to try to move from what was already a more fragmented NHS workforce planning to work into an integrated health and social care workforce planning. We don't have matching data or data sets that help with that. So I understand the why we did that, but I would say that was a very tough call. And as a result, it would feel that some parts of workforce planning has got lost in that in order to try and achieve an integrated workforce plan, which in the end often is so high level that we don't quite understand what that means. And I think that's about the approach that needs to be questioned.
Thank you very much. And finally, and very briefly, Brian.
Thank you. Yeah, I was going to say that following on from that, I think that I wanted to say that the issues around technology and the ability, that it's not a technology issue, it's a change management issue, because the technology exists out there to be able to do that, to do all of this sort of integrated work and collaboration, communication work. I think it boils down to a single question really around the implications of data sharing, which leaves me with the question, who should own the patient data?
Patient.
Thank
Individual,
you.
Absolutely.
That's what I call brief, succinct and unanimous replies. Thank you very much, and thank you to our witnesses once again. As with the previous panel, we haven't completely covered all the territory that we would have liked to do. And so we will write, if we may, to the witnesses to ask you, particularly around the issue of evaluation, which inevitably finds itself at the end of an agenda, but that doesn't mean it's unimportant. It is actually critical. So we will drop you a line about those points. But thank you very much. I'll suspend briefly for a moment.